the clinical in patients at the bedsides. So first talk will be given by our guest faculty, the national faculty, Dr. Suresh Kumar Ongurana, who is the additional professor in the Department of Pediatrics of PGI Chandigarh. And Dr. Suresh is very well known and faculty in, and he will be delivering on the steps of the blood gas analysis. Over to you, Dr. Suresh.
Yeah, thank you, Dr. Mihir. Good evening, everyone. Thank you, Dr. Mihir, Dr. Rohit, Dr. Naladri, and I could see Dr. Subhashis Bhattacharya is chairperson of West Bengal Academy of Pediatrics. I think he must be there in the room.
Yeah, Subhashis Bhattacharya in the scientific chairperson.
Yeah, yes. And thanks to all people who are involved in this webinar. So today we are going to discuss about 7 steps of blood gas analysis. There are actually many steps, even more than 7 steps, but since Rohit told me that you have to tell just 7 steps, so I am trying to cover those things in just 7 steps as told by the organizers. So we'll see what we are going to cover. So we will cover acid-base hemostasis and what are those simple steps to analyze a blood gas, and it will help in it will give a clue to diagnosis and whether patient is responding to interventions or not. This will also helpful in that way also. So as we know that pH is negative log of hydrogen ion concentration, and pH ranges from 1 to 14. So this is a scale of pH, and normal extracellular pH is from 7.35 to 7.45. And the range of pH that is compatible with life is also very broad, 6.80 to 7.80. But it is the intracellular pH which determines the cellular function, and cellular pH a bit lower than extracellular pH. The range is 7.0 to 7.3. And even a 25% change in pH adversely affects the cellular function. So if pH is less than 7.3 or more than 7.52, then there is some abnormality in cellular function. And we know that a healthy adult produces around 300 millicurie per kg per day of CO2 to 2 millicurie per kg per day of hydrogen ion. So this amount of CO2 and hydrogen ion is very huge burden on the body to be eliminated from the body. So the 2 organs like lung and kidneys, they are very important to manage this large amount of carbon dioxide and hydrogen ion. So what are the effects of pH, or why we are worried about acid-base status in the body? Because you know that the hydrogen ion or pH virtually alter all protein and membrane function if they are altered. And in case of alteration in pH, the cellular enzymatic functions may be impaired. There may be impairment of potassium homeostasis. The immune cell function may be compromised. The neurons and muscle excitability, like in cardiac, in skeletal muscles and nervous system, they may be impaired. We know that low pH decreases excitability, and if pH is high or alkalotic pH, it increases the excitability of skeletal muscles and nerves. CNS and myocardium are the most sensitive to pH changes. So these are the organs which we are worried about whenever there is extreme changes in the pH. So what are acid-base buffers in the body? So acid is basically any substance which is added to body or any fluid, and it donates proton. And alkali is the substance which accept protons. So buffer are the substances which prevent changes in pH when any acid or base is added to the body or to any fluid. And what are the important blood buffers or buffer inside the human body? These are bicarbonate buffer, protein buffer, phosphate buffer, and calcium carbonate in bones. So these are the 4 most important buffers inside the human body. Bicarbonate buffer is one of the major buffer. It constitutes 70% of all buffers inside the body. And this equation you must be seeing or reading since yesterday, that whenever there is hydrogen ion addition, it combined to bicarbonate buffer and it convert into H2CO3, and this dissociate into water and carbon dioxide. And in this equation, the lung is able to control CO2. So whenever there is excess CO2 generation, the lung will be eliminating the CO2, and the kidneys control bicarbonate and hydrogen ion. Phosphate buffer is less important extracellular buffer due to its low concentration. Ammonium is important urinary buffer, and the bones also important buffer, and it it buffers around 60% of non-volatile acids. So these are the few of the important buffers, and bicarbonate is most important buffer inside the body. So coming to 7 steps of ABG analysis. So these are the 7 steps which we will see in next 20 minutes or so. So first step is data accurate? The next step is normal or abnormal. The next third step is we have to see whether CO2 is abnormal or normal. The next is we have to look at bicarbonate, whether it is normal and abnormal. So we have to see if pH is abnormal, what is the primary cause of it, whether it is abnormality in CO2 or abnormality in bicarbonate, which is causing abnormal pH. And then we have to see whether carbon dioxide or bicarbonate is matching with the pH. And next step is, does CO2 and bicarbonate go the opposite direction of the pH? So we'll see all these steps in next slides. And the next step is to see whether PO2 and SaO2 or pulse pressure or the partial pressure of oxygen in arterial blood or saturation of oxygen in arterial blood is normal or not. So coming to data accuracy, most of the time the machines these days are very accurate. So this is not a usually problem that the data is inaccurate, because these are very sensitive machines. Unless there is problems in the calibration, then there may be some problem, but most often the problem in data accuracy is not very important these days. So we can check the accuracy of the data by using this equation, like hydrogen ion is equal to 24 into PCO2 and bicarbonate. And when we put the values from the blood gas, like here we had done this, so whatever the number we get, if it is like 40 here, so this 40 should be the last 2 digits of the pH after the decimal point. So if it is like, if CO2, if this number is 40 and pH is 7.40, it means that data is accurate. But this is applicable only to the a range of pH. If the pH is out of range, then we have to use available. There are some tables are available by which we can see whether the data is accurate or not. The next step is to see the pH. So normal pH, you know that it is ranges from 7.35 to 7.45, and any pH less than 7.35 is acidic, and any pH more than 7.45 is alkalotic. So just by look at pH, whether it is 7.35 or if it is just 7.35 to 7.45, if it is in the normal range and we don't see other parameters, then we can't make a guess that whether pH is acidotic or alkalotic. So if the pH is normal and if the bicarbonate and CO2 are all normal, then we can say that everything is normal. So if the pH is in normal range, but there is abnormality in CO2 or bicarbonate, even then there is some acid-base abnormality may be there, right? So this is the normal value. If the pH is less than 7.35, it is acidic. If it is more than 7.45, it is alkalic. For CO2, the normal range is 7.35 to 35 to 45, and for bicarbonate, the range is 22 to 26. But for the practical purpose or for analyzing blood gas analysis, these are the numbers that we should remember, that any pH less than 7.40 is acidic and more than 7.40 is alkalotic. CO2, if it is less than 40, it is respiratory alkalosis, and if it is more than 40 is respiratory acidosis, and same is for bicarbonate. That number for bicarbonate is 24. The third step is to examine the PCO2. We know that normal range is 35 to 45. So if it is below 35, it is alkalotic, and if it is more than 45, it is acidic. So this is the relationship between pH and PaCO2. If there is increase in PCO2, there will be decrease in pH. So this is acidic pH, and we label it as respiratory acidosis. And if there is decrease in PCO2, it will lead to increase in pH. We call it as respiratory alkalosis, right? The next step is to analyze the bicarbonate level, and normal level of bicarbonate is 22 to 26, and if it is below 22, we label it as acidotic, and if it is more than 26, label it as alkalotic. The relationship between pH and bicarbonate is like this. If there is increase in bicarbonate, the pH will increase, and we label this as metabolic alkalosis. And if there is decrease in bicarbonate, it will lead to decrease in pH, and it is metabolic acidosis. So then we have to match bicarbonate and PCO2 with the pH. If the pH is acidotic and CO2 is also acidotic, it means that CO2 is also high, then the acid-base disturbance is called by respiratory system, and we'll call it as respiratory acidosis. And if the pH is alkalotic and the bicarbonate is alkalotic or bicarbonate is high, then the acid-base disturbance is called by the metabolic system or renal system, and we call it as metabolic alkalosis, and reverse is also true. So these are the primary processes, how CO2 affect pH and how bicarbonate affect pH. In cases of respiratory process, the effect is known as seesaw effect. If there is increase in PCO2, pH will fall, and with decrease in PCO2, pH will rise. Okay, but in metabolic process, the effect is elevator effect. It means that with increase in bicarbonate, the pH will also increase, and with decrease in bicarbonate, pH will decrease. So just remember seesaw effect and elevator effect of respiratory and metabolic processes respectively. The next step is, does CO2 and bicarbonate go in opposite direction of pH? So if it is so, then we should maybe it is due to the compensation or compensatory mechanism. So let us take an example. If pH is acidotic and CO2 is acidotic, so it means that pH and CO2 are going in same direction. It means that with increase in CO2, pH is falling down. So it is seesaw effect. So respiratory acidosis is the primary process. But if the bicarbonate is elevated, which is opposite to the pH, then it means the increase in bicarbonate is due to compensatory mechanism or metabolic compensation is there. I think this much is clear. So the next is compensation, how the compensation take place. So for metabolic processes, the compensation is by lung or alteration in CO2, and for the respiratory processes, the compensation by kidneys by increase or decrease in bicarbonate. So for metabolic acidosis, with every 1 decrease in bicarbonate, there is 1 decrease in PCO2. For metabolic alkalosis, for every 1 increase in bicarbonate, there is 0.7 increase in PCO2. For respiratory acidosis, acute or chronic, for every 10 increase in PCO2, there is 1 increase in bicarbonate for acute, and 3 increase in bicarbonate for chronic respiratory acidosis. For metabolic alkalosis, for every 10 decrease in PCO2, there will be 2 decrease in bicarbonate and 4 decrease in bicarbonate for chronic respiratory alkalosis. So we can remember that for respiratory acidosis, the number are 1 and 3, and for respiratory alkalosis, the numbers are 2 and 4. So odd numbers for acidosis and even number for respiratory alkalosis. This is another formula with which we can find out the expected CO2 in case of metabolic acidosis, and expected CO2 can be calculated as 1.5 into bicarbonate plus 8 plus minus 2. So coming to compensatory mechanisms, so lungs are responsible for respiratory compensations and kidneys are responsible for metabolic compensation. So what kidneys will do, they absorb or excrete bicarbonate based on changes in PCO2 in the same way. Like if PCO2 is more, then kidney will retain more of the bicarbonate, and if PCO2 is low, kidney will retain less of bicarbonate. And lungs will wash out or retain CO2 with the change in bicarbonate in the same way. So compensatory mechanisms. So if there is metabolic acidosis, the respiratory compensating mechanisms may be in form of increased minute ventilation. Whereas if there is metabolic alkalosis, then there will be decrease in minute ventilation. For respiratory acidosis, there will be increased resorption of bicarbonate in proximal tubules and increased renal excretion of bicarbonate of sodium in of hydrogen ion in distal tubules. In respiratory alkalosis, there will be decreased renal reabsorption of bicarbonate in proximal tubule and excretion of hydrogen in the distal tubule. So these are the various compensatory mechanisms. Coming to important rules of compensation. So body always try to normalize the pH, but it will never overcompensate or normalize the pH to exactly to 7.4. So whenever there is pH is normal or there is overcompensation, then think of a mixed disorder. Respiratory compensation starts within minutes, but it will reach maximum in 12 to 24 hours. And in metabolic disorders, CO2 may increase more than 65 millimeter mercury. In metabolic compensation, it starts within hours by bicarbonate absorption, but peaks in 5 days due to excretion of the ammonium. And maximal increase in bicarb during acute compensation may be up to 30 to 32. And in cases of chronic respiratory acidosis, the levels may increase up to 45 milliequivalent per liter. So next step is to assess oxygenation. So we know that PO2 is 4 to 5 times of FiO2, and normal value of PO2 ranges from 80 to 120. The normal PF ratio is 300 to 500, and value less than 300 indicate clinically significant gas exchange. And we know that these days ARDS is also divided or severity classified based on PF ratio and OI. So we can have a good amount of assessment of oxygenation and ventilation by looking at PO2 and PCO2. So the clinical status of the patient also guide us toward the interpretation of blood gas analysis. So we should assess patient clinically first. We should know what is the patient status, and then based on the status, we should expect beforehand that what we are going to see in the blood gas. Look at the volume status, urine output, GCS of the patient, and breathing pattern before looking at a blood gas. So these are the basic steps. First, we have to check the accuracy. We have to see whether it is acidosis or alkalosis. Identify primary disorder, whether it is respiratory or metabolic. If there is any compensation, we have to calculate by using rule of thumb. We have to look at oxygenation and ventilation by looking at PO2 and SaO2 as well as PaCO2. And then based on a history and examination and interpretation of blood gas, we can identify the cause, and then it can help us in treating that particular cause, or we can identify the severity of the problem, right? So let us go to this case. This is a 2-year-old female who presented with 5 days history of polyuria and polydipsia and rapid breathing for 1 day. She had tachypnea with clear chest and high blood sugar values. So this is the blood gas of this child. So we can have answers from from the participants. They can type in the chat, and then we can discuss about that. So what is the interpretation in this blood?
Someone severe metabolic acidosis from Shubhasi Saldar.
Okay, all right. Okay.
Metabolic acidosis with respiratory compensation. Dr. Dibba has answered.
Yeah.
Severe metabolic acidosis with respiratory compensation. Narayana has answered.
Yeah, very right. So you
metabolic
know
acidosis with compensated respiratory alkalosis. Many answers came.
Yes, yeah. So that's a right answer. But in this patient, you see that the primary process for low pH is low bicarbonate, and since CO2 is very low, which is opposite to the change in pH, so this is due to compensatory mechanism. Decrease in CO2 is due to compensation. The 8th step is we should remember that for any child with metabolic acidosis, we should calculate anion gap, and this is the formula for anion gap: sodium minus chloride plus bicarbonate. And normal anion gap is 10 to 14, and if one value we have to take for calculation purpose, it is 12. If there is any anion gap more than or equal to 20 millimole per liter, then there is a primary metabolic acidosis regardless of pH or serum bicarbonate concentration, right? So these are the few causes of high anion gap and normal anion gap metabolic acidosis. The common causes being uremia, diabetic ketoacidosis, lactic acidosis due to shock or hypoperfusion, and sometimes salicylate toxicity and renal failure. So these are the few important clinical conditions which lead to high anion gap metabolic acidosis. And normal anion gap metabolic acidosis occur if there is increased losses from the GI tract, like from fistula, ureteroenterostomy, or excess saline administration, diarrhea, carbonic anhydrase inhibitors. So these are the common causes which lead to normal anion gap acidosis. If there is metabolic acidosis, then it is also desirable to calculate delta ratio, which is the ratio between delta anion gap and delta bicarbonate. And these are the values which suggest us what is the exact cause. If the delta ratio is less than 0.4, then it is hyperchloremic acidosis. If it is between 0.4 to 0.8, it is normal anion gap and non-anion gap metabolic acidosis, and it is commonly seen in AKI with value of less than 1. If the value of delta ratio is 1 to 2, then it is anion gap metabolic acidosis. Usually causes are lactic acidosis and diabetic ketoacidosis. And if it is more than 2, then anion gap acidosis with pre-existing metabolic alkalosis. So with this, we can even, we can even pinpoint what is the main problem in the patient. Okay. Then there is delta gap, which is calculated as calculated anion gap minus normal anion gap plus measured bicarbonate. And if the delta gap is greater than the normal concentration, then there is underlying metabolic alkalosis. But if delta gap is less than the normal bicarbonate concentration, then there is underlying non-anion gap metabolic acidosis. Osmolar gap is also important to calculate. We know that the normal osmolar gap is less than 10, and some conditions like lactic acidosis, alcohol ingestion, or toxicity due to methanol poisoning, then or diabetic ketoacidosis, there may be high osmolar gap. If there is non-anion gap metabolic acidosis, it may be due to loss of bicarbonate from the GI tract or kidneys. And then we have to calculate urine anion gap, which is given by this formula. And if there is renal loss, then the urine anion gap is positive. And if losses are from gastrointestinal tract, the urine anion gap is negative. So, Dr. Rohit, do we have some more time? We can take 1 or 2 more cases, or?
Yeah, yes, sir. We have time, sir.
Go ahead.
Okay, yeah. So this is another child, 3-year-old boy who was previously thriving well and now presented with 5-day history of vomiting and drowsiness. He had 8 to 10 episodes of vomiting daily since last 5 days, and these were non-bilious, non-projectile vomiting. The positive triage finding in this child were respiratory rate of 12 per minute with drowsiness and features of mild dehydration. So based on this history, what are your any striking finding on history and triage? So this child has persistent
Metabolic
vomiting.
acidosis.
Okay.
Answer is
So
metabolic
history,
acidosis.
based on history, you expect metabolic alkalosis, right? Not acidosis. Because child has persistent vomiting, and due to vomiting, there is loss of acid from the GI or from the stomach. Okay. So due to alkalosis, child may be having very low respiratory rate, and he's drowsy also. So that may be due to severe metabolic alkalosis. So this is the blood gas of this child. So again, as pinpointed by Rohit, the metabolic alkalosis is there. And what about CO2? Can someone interpret this blood gas based on those 6-7 steps?
Yes, sir. They are answering, sir.
Yeah. So what is their answer? Is it compensation, overcompensation by respiration, or what?
Mixed disorder by Dr. Alok.
So you know that pH is alkalotic, and for this alkalotic pH, the more the primary cause is increase in bicarbonate. So how much bicarbonate has increased? It has increased by 20, right? 20 increase in bicarbonate. What could be the corresponding CO2?
Metabolic alkalosis plus respiratory acidosis.
So it is partial
Compensated.
respiratory compensation.
44 to 50 answer is coming, sir.
Okay, so it is metabolic alkalosis with partial respiratory compensation. Okay. Coming to next child, this is a 6-month-old child who's having VSD, and he is receiving Lasix infusion for 5 days. Okay, continuous Lasix infusion, and this is the blood gas of this child. So what are the interpretation of this blood gas?
Metabolic alkalosis by Dr. Pradeep.
Okay, very right, metabolic alkalosis. And what about CO2? Is it CO2 compensated or excess or more than the expected CO2? So bicarbonate has increased by 26. So what could be the CO2 for this level of bicarbonate?
Respiratory acidosis. People are answering, sir.
Yeah, so CO2 is more than
expected. Answer.
So it is basically mixed disorder, metabolic alkalosis and respiratory acidosis. So now what happened is someone has intubated this child, and post intubation child is now on ventilation, and this is the blood gas. So can anyone tell what has happened here?
Metabolic alkalosis with respiratory acidosis. Dr. Shubhiksa.
Yeah, definitely there is metabolic alkalosis there, but you see the
Hyperventilating. People are answering.
Yeah, very right. So CO2 has suddenly decreased
CO2
from
wash
70 to
out.
40. Okay, CO2 has washed out. Bicarbonate has some decrease in bicarbonate, but you know that the kidneys will take time to remove that amount of bicarbonate. So what has happened is there is sudden fall in CO2 after ventilation. pH has gone up due to sudden fall in CO2, but bicarbonate is still high. So what is this state called?
Metabolic alkalosis, they are answering, sir. Post hypercapnia.
Yes, post hypercapnic metabolic alkalosis, right? So these are the causes of metabolic alkalosis. If there is any metabolic alkalosis, we have to look at urine chloride levels. If the urine chloride are less than 20, then common causes of vomiting, NG aspiration, use of diuretics, CF patients, post hypercapnic and congenital chloride diarrhea. And if it is urine chloride is more than 20, then there may be due to excess of steroid use, Liddle syndrome, Bartter, Chittelman, hypokalemia based on whether blood pressure is normal or high. I think, yeah, one more case I want to take. Yeah. So this is last case, 10-year-old girl, SMA type 2 or 3. And she presented with 2-day history of irritability with GCS of 15. And this is the blood gas. 7.36, PO2 58, PCO2 54, bicarb 30, saturation 92%. And so these are the electrolytes. So what is your interpretation? So this is a chronic problem. So chronic neuromuscular disease is there. So it is basically chronic or type 2 respiratory acidosis there.
Respiratory acidosis with metabolic
compensation, right?
Yes.
So what is other important
answering students, sir?
Yeah, what is other important finding here? You can see that the PO2 is very low, 58, and saturation just 92%. So what does this mean? And you will be very careful when you treat this kind of patients. So this is chronic respiratory problem. Hypoxemia is also there. So in such kind of patient, what happens is the respiratory drive is maintained by chronic hypoxemia. Okay, when you supplement them with very liberal oxygen, then they will go into respiratory failure, right? So this is what has happened. Someone has started this child on oxygen and saturation improved to 98%, but after 1 hour, child found to be unresponsive or gasping. Okay, so this is the blood gas after the oxygen supplementation. PO2 has increased. There is very massive increase in CO2, which led to fall in pH. And so this is acute respiratory acidosis due to abolition of the respiratory drive due to correction of hypoxemia, and it had led to hypercapnic coma. Okay, so learning point from this case is avoid overzealous or supplementation of oxygen in type 2 respiratory failure. In such kind of children, the ventilatory drive is maintained by hypoxia. Okay, so I think since time is over, I can come to the conclusion slide. Yeah, so these are the...
Sir, time is there, sir. You can finish those 3 cases, sir.
Okay, is there
Me,
still
sir,
time?
is it?
Yes,
Fine.
yes, you can. Yes, very interactive session is going, so you can just discuss 1 or 2 more cases. Okay?
Yeah, yeah. There are 2 are only there, I think. So
yes,
they are answering nicely, sir.
Yeah. So this is another blood gas. pH is 7.4, PO2 88, PCO2 22, bicarb normal, everything else is normal. So what has happened here? See, pH is absolutely normal, but PCO2 is low, and it is not affecting your pH.
Excess heparin.
Very right. So if there is excess heparin, you know that we shouldn't use too much heparin. These days there are pre-filled heparin syringes or pre-primed heparin syringes, but one is we just fill heparin in the normal syringes, and if there is excess heparin, then it can decrease the value of PCO2, and in addition, calcium values may be low, but there won't be any effect on pH and PO2, right? So this is the next case, which is a case of severe ARDS, and these are the serial values, maybe 6 hours apart. So this, the main finding I'll tell you what is here is you see there is low PO2 here and low PO2 in the third blood gas, and child has not shown any improvement clinically or your ventilation parameters and oxygenation, but in between one blood gas shows PO2 of 98. So what is the problem here? And there is also increase in saturation to 99%, but again within few hours the blood gas parameters were same as that of the first blood
Dr.
gas.
Pradeep answered the air bubble.
Very nice. So Rohit, you have primed them with all these interpretations, right? In like since last few days you are in
Yes,
this
sir.
workshop.
Students and the participants only answering, sir.
Yeah, yes, good. So it is air mixed sample. So this, if there is any air, the changes on PO2 or saturation will depend on volume of the air bubble. So it also depends on the size of the bubble, the original PO2 in the sample, extent of mixing, and how long exposure has been there. So to avoid such kind of problems, we should dislodge any bubbles by gently tapping the sides of the syringe and expel the bubble before storing samples for analysis or before doing analysis, right? So this is a 5-year-old boy who was diagnosed case of ALL, and you know that TLC is very high, and he was having slight tachypnea, chest exam was normal and saturation was 97%, and someone sent blood gas for this child, and this was the blood gas. So can you tell us what is the problem here?
Yes, sir. They are typing, sir.
Yes. So what is the problem here is very low PO2 and normal SaO2, okay, and rest of the parameters are more or less okay. So why there is
High
difference between-
leukocyte can affect blood gas, sir. Answer they give, sir.
Yes, they
Dr.
are.
Raghuram.
Yeah, just by looking at the blood gas by PO2, one may say that it is type 1 respiratory failure, but it is due to high leukocyte count in this patient and high platelet count, which can lead to pseudohypoxemia. So the solution to such kind of problem is we should, after obtaining sample, keep the sample on ice and process as soon as possible, because otherwise the leukocyte will consume the oxygen. Okay. So I think we are done. So these are the 7 steps which Rohit has told me to cover, just 7 steps. First of all, we have to check the data accuracy, whether pH is normal. Then we have to look at CO2 and bicarbonate, and we have to match CO2 and bicarbonate with the pH. And we have to see whether CO2 and bicarbonate are going opposite direction of pH to see if there is any compensation happening. And then we do have to check for oxygenation and ventilation status. I have not covered about the importance of PCO2 and its relation between end-tidal CO2 and what are the mechanics going on in the lungs or in the patient, but that is also important component. And in cases with metabolic acidosis, we have to calculate high anion gap metabolic acidosis, or we have to look at anion gap, delta gap, or osmolar gap. And if there is normal anion gap metabolic acidosis, we have to check urine anion gap, osmolar gap, and pH. And for metabolic alkalosis, we have to look at the urine pH and chloride. And background history is very important before interpreting the blood gas, because you should be having it beforehand. Only then you can interpret blood gases in a better way. So thank you, West Bengal Academy of Pediatrics and the Intensive Care Chapter Kolkata, Dr. Mihir, Dr. Rohit, Dr. Niladri for inviting me. Thank you very much.
Thank you, Dr. Suresh. So it was an excellent session with lot of interaction from the participants, and all of the most, I think there is maximum of them has already answered, and they took part in the discussion. So again, Dr. Suresh, to making it a more interactive, I think it will be more helpful for the participants. And again, thank you again for your this lucid and very interactive presentation.
Thank you. Thanks.
So, sir, a few questions are there. Dr. Niladri, can you just coordinate with the question answer? Many we have answered. Yeah, mainly the osmolar gap. One question just now came.
Sure, sir. So, first question is, what is the importance of osmolar gap?
Osmolar gap is seen in few conditions, like if there is unmeasured osmol. So it is basically difference between your calculated osmolality and measured osmolality, right? So if you are calculating osmolality based on just your blood sugar and sodium, okay, when you are calculating on bedside, and if osmometer is measuring osmol and it takes into account all the osmols which are there inside the body. So if there is any other osmols which are not taken into account for calculating the osmolality, like there may be some alcohol like methanol poisoning, ethanol poisoning, then the osmolar gap will be very wide. Okay, so that in this condition, there is widening of osmolar gap. So if there is increased osmolar gap, then this can point toward the particular diagnosis.
Sir, another one, I think regarding air bubble, they have asked, sir, sometimes when a bubble is present, huh?
So yeah, air bubble, I think will be dealt by you only, Niladri. So we can skip
We
this
can
That
question.
will
skip
be
that.
repetition. So,
Yes.
so there is one question in this child, the case scenario you have shown on the VSD. The VSD child with metabolic alkalosis due to LASIK, should we adjust our ventilator pressure to allow some CO2 retention up to 50? Is it clear question? I'm not what is actually trying to ask. I'm not sure.
Yeah, we can. The only issue with that case is if this patient was put on ventilator, then the CO2 may fall very rapidly, right? So then there will be a very increase in like sudden increase in pH due to CO2 washout. So maybe with lesser of rates, we can try to avoid decreasing CO2 very rapidly. So that we can try that. Yeah.
Okay, I think most of the questions are now covered. They have already.
Sir, another one just now they asked, which urinary buffer is more important, phosphorus or ammonium?
Ammonium buffer
Oh,
is
sir, you have
important.
asked. Okay,
Yeah,
okay.
already answered.
Thank
Sir
you, sir.
answered. Sir answered. Yeah.
Thank you, sir.
Yeah, so air bubble, Niladri will take up in the next session. Okay.
Sure, sir.
Thank you again, Dr. Suresh. And I think all the questions have been answered. And we have also WhatsApp group. You can post the questions in the WhatsApp group. We'll try to answer there again. Okay. Over to you, Rohit.
Yeah,
Thank you very much, sir, for
Thank
the
you.
nice
Thank you.
interactive sessions. So the next session will be by Dr. Niladri Shikhar Punia, and which is on blood gas analysis, the analytical errors. So Dr. Niladri has done his critical care training from CMC Vellore, and he was there for almost more than 3 years. Then he was PIC in charge of AIMS Rishikesh. Currently, he is associate professor at AIMS Kalyani. So Dr. Niladri, the screen is yours.
Okay. Thank you, sir. Thank you, West Bengal Academy of Pediatrics, Mihir, sir. I will just go to the screen sharing. Screen is visible, Rohit, sir?
Perfect. Everything is perfect. Please go ahead.
Thank you. First I will start the session with a story. This was actually a true event which happened in the year 2008, around 15 years back. There was one jet, Boeing 777, which was going from Beijing, China to London. And it was a long flight, as you can see. This is like mostly covering the whole of the world, around 18 hours flight. And the whole of the flight was mostly smooth. But just before the flight was going to land, suddenly both the engine stopped, and both the pilots they don't know what happened suddenly, why the flight has stopped. Then the flight somehow they like crash landed, nobody expired, but this had led to a huge investigation later, which found that when the flight is going, you can see there is some area where it is crossing the polar area. So in the polar area, there is the temperature, it can drop to -20, -30 and all. And in the flight, the fuel, jet air fuel, it can contains very little amount. That amount is only 2 drops in a gallon of air fuel. The 2 drops of this water vapor that can freeze, and that can make a small freeze this sedimentation. And when the flight is going very smoothly, this sediment they can float. But when the flight is going to land, that time the pilots, they will increase the energy, the engines will rev more. So at that time, that amount of sediment, ice, they can go and they can clog the this vessel, this engine input, and that can lead to this type of failure. So the point here, what I want to tell is, even 2 drop of water vapor can cause that type of accident. And then you should know that just like your air fuel in our body, if you are measuring the partial pressure of something, even small amount of other material like oxygen, carbon dioxide, and all those things, that can cause a problem. That is the importance of this story. So now I'm going to tell the outline. So maybe next 15-20 minutes, we'll be talking about pre-analytical error. What is this? What are the common sources of pre-analytical error? How to correct them? And some prerequisites you should do before you taking a sample of ABG. First, we'll see what is this brain-to-brain loop. This is a concept which was given by Lundberg in the year 1981, where he has told that whenever we are ordering any test, not only blood test, not only blood gas, any test, the first thing what you should come is, in the physician's mind, there will be the thought, what is the cause of this problem and why I need this type of test. So it is mainly in the mental stage, this cognitive stage. After that, he will give the order of testing some blood sample, and there are some intermediary steps you can see there, and followed by the laboratorian's brain. When he will interpret the result, then he will try to interpret what may be the problem, and he will inform the physician. So there the loop is closing. So this starts from the physician's brain and closing in the laboratorian's brain, and in between there are intermediary steps which can be automated or it can be manual and cognitive. So as you all know, manual and cognitive, they are more prone for error, but this automated steps, it can be corrected by the machineries. Nowadays we have very fine machineries. So that's the importance. Now, what is this pre-analytical phase we are telling? So this is just a cartoon which is showing whenever we are telling or ordering any type of test, first we'll just tell the patient about the blood test we are going to do. We'll order that. After that, we'll just tell them to collect the blood sample. So pre-analytical phase is the phase when the blood is given before the analyzer. And after that, there are some chemical reaction is going on where there you can see the 1 second. We can see the analytical phase where you can see there is some this chemical reaction is going on, and the post analytical phase where after the result is there, you will put some dates and all, and obviously you will cross check with the patient's data, and will send the data to the clinician who will interpret the result and will treat the patient. So this is the whole cycle. So essentially pre-analytical stage is the stage before inserting the sample into the analyzer. Okay, so this is a study in the year 2006. So where they have shown out of all the errors, most of the errors occur in the pre-analytical phase, which is a whopping 46 to 68.2%. And you can see what are the errors. There can have incorrect sampling, incorrect identification, sample handling on transport problem, sample condition may not be optimal, insufficient sample. All those things, they can constitute a huge amount of error in the pre-analytical stage itself. So what can be the sources of error? So the error can be from ordering the stage, ordering the test, from identification, collection, transportation, or in the preparation phase. Okay. So first we will go one by one in the ordering. So ordering means when you are ordering a blood gas, what is your question you are asking? Why you want a blood gas? So you have to be double sure before ordering a blood gas. Usually in most of the time, the blood gas is ordered in the following 3 scenarios. I just summarized in a little bit simplified manner. If you are suspecting some gas exchange abnormalities, where the cause can be acute or chronic pulmonary disease, acute respiratory failure, or acute respiratory distress syndrome, or it can be in a cardiovascular disease. Yesterday, Narayanan sir has nicely told about the lactate part. Where you are suspecting the patient might have cardiac problem, you will want to see the lactate value. And in few cases where you are suspecting some acid-base disturbances, depending upon the clinical history. In all these 3 scenarios, mostly you will order for a blood gas. But mostly in intensive care settings, you know, Blood gas is done mainly to see the ventilation and the oxygenation part. So ventilation will be taken care by the CO2 and oxygenation by the PO2 part. So when you should do a blood gas in an intubated patient, actually there is no clear-cut answer to that. This will depend upon the setup where you are working and how is the patient. Usually most of the time in intubated patient, at least early morning we want to do a blood gas. So that doesn't mean routinely you will do blood gas in all patients. If you are suspecting some problem is there, or anytime you are changing some ventilator settings, you will repeat the blood gas. What is the importance of that is, most of the time there can be iatrogenic anemia because of excessive blood sampling, especially in case of infant and neonates. That can be avoided by just repeating the routine blood gases. If patient is stable, you don't want to repeat a blood gas in those scenarios. Next, we will talk about little bit about consistency. Already Suresh sir has told you how you will know the consistency by this formula, where you know the H plus concentration is dependent upon the PaCO2 and bicarbonate ratio into 24. And you know, if the patient is having a very abnormal pH, which is not consistent with the PCO2 and bicarbonate, then there is a problem. You have to repeat the blood gas in those scenarios. Or if the PO2 is very high, but the patient is in room air, then you know there may be some problem. Or in extremes of ranges, pH is very low, 6.8, 6.7, patient is perfectly all right. Or pH is 7.5, 7.6, patient is not hyperventilating, then you know there might be some problem. So these are the areas where you want to repeat your blood gas. Another thing I want to tell is identification. This is more important than any other chemistry analysis. What do you mean by identification? Identification means whenever a patient you are ordering blood gas, you have to know the ID of the patient. ID of the patient. That means what is the patient's name, what is the time of collection, where is the patient located. You don't want to miss someone blood gas, mix someone blood gas with else's. And if the patient is having any critical result, this is usually not to a point of care testing, but if you are sending blood gas to a central lab, if there is any critical result, you have to tell the clinician, tell the lab personnel to call and inform if there is a critical result. Nowadays, with the automated barcoding, you know, they're very easy to do. You can paste one barcode on the ABG syringe and on the this patient's leaflet, and you know the both the samples are from the same patients. So these are the important things you should know. After that, temperature, very important. When you are taking blood sample, what is the temperature of the patient? If the patient is having fever or the patient is hypothermic, site of sampling, whether it is from artery, whether from vein or capillary sample, what FiO2 the patient is breathing, is the patient in room air, patient is having 100% oxygen by NRM, or patient is intubated getting oxygen. Then ventilator status, whether patient is in spontaneous respiration or the patient is in intubated state. Time since the last ventilator change. That means if you are changing any settings, at least 15 to 30 minutes has to be given for a steady state to maintain. After that only you should repeat a blood gas. Next is dynamic testing. What do you mean? Dynamic testing means when you want to see with the change in the position of the patient, whether there is a change in the blood gas. You can do a blood gas in the supine position, and you can do the sitting position. In all those scenarios, you have to monitor, and you have to mention the position of the patient. Next is clinical status. Clinical status is of utmost importance. What do you mean by clinical status? What is the clinical history? Whether the patient is having a problem because of vomiting, diarrhea, or whether the patient is hyperventilating, because especially in case of small child, when you are taking blood sample, child is crying vigorously, they can have less PCO2 because of that. These are the important things you should always know and always mention before you want to do a blood gas. Next, we will go to the collection part. So there are mostly three broad areas from you can take the blood gas. One is venous blood gas, arterial, and capillary. Venous blood gas usually from the peripheral veins. If you are having maybe internal jugular cannula, you can take from IJB line, or very less likely, rarely pulmonary artery, you can take blood gas. Arterial blood gas can be taken from indwelling arterial catheter if you have an art line, or directly poking the umbilical artery in case of neonates from umbilical artery. Capillary blood gas from capillary bed of skin, it can be from finger or the heel. So what is the importance of this slide is, how will you know which one to take? So there is this a study which they have shown the correlation between arterial and the capillary blood gas. And they have shown that pH and PCO2, they will correlate well with arterial blood gas, but PO2 usually not correlate. So if you are suspecting some problem in the lungs where the PO2 might be affected, in those situations, better to go for the arterial gas rather than the capillary blood gas. Similarly, you can see in the right side, there is this graph where you can see the VBG and ABG scenario. And you can see the VBG and ABG, they will mostly correlate other than the PO2 part. Why PO2 part? Because obviously it is a venous gas, so the venous PO2 obviously will be low. And you can use this simple equation to more or less like correlate between ABG and VBG pH. So ABG pH will be VBG pH plus 0.05, and ABG PCO2 will be VBG PCO2 minus 5 millimeter of mercury. Very simple to remember. This you can use. So another important thing what I want to mention is, if the patient is very sick and patient is having 2-3 inotropes and still the patient's peripheries are cold, peripheral circulations are less, in those scenarios better not to go for the venous gas, because the venous circulation itself is low and it might not give you a very accurate number. In those scenarios, always go for the arterial blood gas. Okay, so this is just a cartoon to show how you will draw a blood gas. So first and most important thing I want to tell about the Allen test. What is the Allen test? You know, before taking a blood samples, you have to ensure the core lateral circulation is patent. So how will you do that? This is shown in a adult or adolescent maybe. So you just tell them to make a fist 2 to 3 times to drain the blood from the pump. After that, you block both the radial as well as the ulnar artery by blocking with the finger, and you will release the ulnar artery and see whether the flushing area has become red within 15 seconds. If it is not becoming red within 15 seconds, you know there is a problem in the collateral circulation. So you might not want to poke in that radial artery. You might want to see in other areas of the blood of the body. And how will you take blood from this wrist from the radial artery? You have to extend it by putting a little bit of gauze piece or maybe one NS bottle, and you can just try to fix the other fingers by using a strapping. Some of the centers, they use local anesthetics. Usually in pediatric, we usually don't use, and you use a cannula, or maybe you can use your ABG syringe, and the angle usually is 30 to 45 degree, and you can aspirate the blood. This is the from the arterial blood sampling. This is a small video where I want to show how will you draw a blood from the art line. If you have an art line, how will you draw the blood? Let's see if it's playing on. 1 second.
A pressure bag connected to the transducer and the
I'll
flush.
just pause the silent this one. So you can see here usually in the arterial line where you have a continuous arterial BP monitoring, you have this pressure bag where the pressure is applied to prevent the backflow of the blood, and a transducer is there where the arterial this pressure is getting transmitted, and it is converted to an electrical signal. So first you have to see whenever you are taking a sample, this point of the transducer. So this of the part of the transducer, part of this assembly, this is going towards the patient, and this blue one is the stopcock. If you see this stopcock is towards this side, that means this is the this area is blocked. The blood is not coming in this way. This is the plunger. You can just pull it, and the blood, this hep saline will be flushed. So after that, first what you have to do is, under all aseptic and antiseptic condition, you just take a 10 cc syringe and you try to aspirate little bit amount of blood. We'll just show you. Yeah. So they have connected a 10 ml syringe to the stopcock, and first you see the stopcock is towards this side. That means this is blocked. So what the blood won't be coming. So then they will slowly rotate it towards the below one. So from below one, this fluid is coming. So if now the stopcock, the syringe is connected directly towards the patient. So if you can aspirate the blood, aspirate here, the first little bit amount of hep saline will come, because you are giving hep saline towards the line, and after that slowly the blood will come. You can see. So usually there will be diluted blood. After that red colored blood will be there. Yeah. After that, you close the valve. How will you close all the valves? You just make it in between. In between, if you keep it, all the valves will be closed. Then you discard this syringe. This is the diluted blood. You won't be able to take this. This will give false result. So you'll discard it. After that, you will just connect the ABG syringes. So these are the syringes where there are already premixed dry heparin is there. So no need to take liquid heparin. You just connect it. Then again, you will rotate the stopcock and connect the syringe towards the patient side, and you draw the blood, and you rotate the stopcock towards the patient side, and you stop it, so the blood won't be coming. After that, you will send the sample for the analysis. After that, what important thing you have to do is you have to clean that area. So how will you clean that area? First thing, you have to rotate this one towards the patient side, so the blood won't be coming back, and you take 2 to 3 clean gauges, and you try to pull this yellow color thing, so that little bit amount of hepsaline will be flushed, so that blood won't be there in that port, because it can be a source of infection. After that, you can directly rotate the knob and you can flush it. So this is the few are the steps. These are the steps with which you can take the blood sample from the art line. So from the capillary blood. So why the concept of capillary blood has come? Because mostly in neonates it's very difficult to collect arterial blood sample, and small babies, if you're poking again and again, you might have complications. You won't be able to have the arterial blood. So there are the concept of capillary blood. So
all the materials you
one
need
second.
to draw a patient sample.
So capillary blood, how will you take it? So these are the few prerequisites. You will take capillary cap, lancet, alcohol wipe, gauze, bandage, and all those things. And these are all capillary tubes. And these are capillary tubes. Already there are hepsaline inside that. Electrolyte balanced heparin is there inside. So usually you will take the blood, especially in case of infants and neonates, from the pump, from the soles. So first you have to clean the area, and you have to make it warm. How will you make it warm? By make it wrap it by 42 degrees centigrade by giving some this warmer or water thing inside a cavity, inside a something. Chamber or something, and you can wrap it inside the sole, and after 10 to maybe 5 to 10 minutes it will be warm. After that, you will just clean the area, and you poke it with the lancet. So for the one important thing you have to is know that ammonium substances such as benzalkonium you should not use. This might interfere with your blood gas, so you should not use that. So after that, you just poke the area, and you can use the capillary blood sample, and you can send it like that. Okay, that's it. So so these are the area, these are the few steps by which you can draw the capillary blood. Okay, so now a little bit about the syringes. Most of the time we are using syringes which are plastic syringes, because glass syringes previously was used, but because of the danger of cutting and all those things, glass syringes are not used nowadays. So syringes, in plastic syringes, mostly one thing you have to know, that plastic syringes, they are partially permeable to oxygen. That means what? Usually, previously, when you used to take the blood sample, the plastic syringes was used to be kept in the iced area, ice pack and all. So if you keep the syringe in the ice pack area, what will happen? The molecule, this plastic molecules, they will be there will be gap in between the plastic molecules. So the oxygen, whatever is there, they can go out or they can go in, depending upon the ambient air where you are doing. Okay, so there will maybe rise or fall of PO2 depending on the starting PO2, that you should know. For this reason only, we are not using this ice pack nowadays. Directly we are taking the blood sample and directly transferring to the blood gas machine. Okay, so now already sir has Suresh sir has told you about a little bit about the air bubble part, and how will you know the air bubble is there or not. So air bubble in a aspiration, it is a very common problem. So usually if the air bubble is there more than 10% of the volume, it can cause problem. So PO2 can be high or low depending upon the ambient air. Usually if the your sample PO2 is very high, some of the blood sample, suppose your ABG PO2 is 300. In those scenarios, your PO2 can be reduced, because from the air bubble which has 150 millimeter of PO2, some of the PO2 can go from your blood sample to the air bubble. So your blood gas PO2 will be reduced. But if your blood gas has less PO2, it can be more because ambient air has more PO2 like that. So depending upon the ambient air, your PO2 can change. Another important thing is the PCO2 part, what we have discussed. PCO2 will be reduced always. And because the PCO2 is reducing, pH will be more. And as you know, the calcium part is depending upon the your metabolic, depending upon the acid base status. If the patient is having alkalotic, obviously the calcium protein binding will be increased. So the ionized calcium might get decreased. So these are the important things you should know. So how will you prevent air aspiration? So most of the time, if you have a air inside the syringe, you can tap it gently so the air can go out. Even after that, if it is not coming, you can rotate it in between your two hands. In all those in that scenario, sometimes that air can go out. And you should always cover the ABG syringe with a cap. Very important. Okay, so now important thing is hemolysis. Sometimes you know that samples will become hemolyzed. So if the sample is hemolyzed, what are the things can happen? So obviously there will be more cell lysis. So the intracellular ions will come out. So they will have increased potassium, decreased sodium and calcium will also happen if there is massive hemolysis. But usually PO2, PCO2 and pH is not affected. And if you are if you are calculating your hemoglobin by the conductance method, so sometimes they can have a hemoglobin estimation error also. Oh, this is very important. Anticoagulant. Usually, we are using only liquid preparation, though it is not preferable, because liquid preparation has 2-3 side effects. First important thing is if your sample is very less, so that liquid heparin itself can cause dilutional error. So all the parameters will be low, because of dilution. And heparin itself can reduce your PCO2 and bicarbonate. We have already seen in the scenario a few slides back. And another important thing is sometimes if your heparin hepsaline contains little bit amount of this air bubble, they can also have changes in the PO2. So these are the important things you should know. So what will be the ideal amount of anticoagulant you should use? It should be less than 5%. So if your sample is 1 ml, only 0.05 ml is allowed. It should not be more than 10%. So if it is more than 10%, they will have all these type of problems. Transportation, very important. Most of the time in your intensive care unit and all, we have a point of care device where the analyze has to be done within 15 minutes. If you are interpreting PO2 or saturation, SaO2 is desired. If you are try to check that whether other parameters are also deranged or not, in those scenarios, better to not wait more than 30 minutes. After 30 minutes, they will have problems. So PO2 will be increased, and because your PO2 will be decreased, because in your blood sample already there are cells which are live cells. They will try to utilize the PO2. Glucose might fall down, and there can be lactic acidosis because the RBCs, they will produce lactic acid. So these are the important things you should know. And always I have told already that you have to avoid exposure to air. Okay, so now this is the preparation part. Preparation means after you draw the blood thing, what you should do is you try to rotate it in between your two hands to prevent the clot formation as well as to prevent any blood, air bubble formation. So air bubble will can remove from the mixing. And just before you give the blood sample into the analyzer, you should do this again to prevent any hemolysis thing or any clot thing go into the blood gas machine. In case of capillary blood gas thing, you can use this figure of 8 method just for 5 to 10 times to prevent the this clot formation and to ensure adequate mixing. Okay, so these are the just few physiological changes. If your temperature is low, your PO2 will be low. If your PCO2 will be low, so your pH will be increased. If your temperature is more, your PO2 will be increased, PCO2 will be increased, and pH will be decreased. This is already we have discussed. If you have very high cell count, suppose patient with acute leukemia, that amount of cell they will metabolize the oxygen whatever is present inside the sample, and they can have low PO2. In those scenarios, you have to check the blood gas as soon as possible in those scenarios. And even sometimes if there are any aberrant hemoglobin, sometimes if you are suspecting methemoglobin, in all those situations, your saturation might be variable because methemoglobin has a different oxyhemoglobin. This saturation curve is this dissociation curve is different in case of methemoglobin. Okay, so this slide is about the temperature correction. So because temperature correction already in the blood gas machine, there is a temperature correction of 37 degrees centigrade. So because of that, most of the time we won't use temperature correction. We just put the sample and the machine itself has a calibration thing and it will give you a result at 37 degrees centigrade. And you don't need to check the actual temperature with which it is corrected. Why it is? Because there is a concept which is given by Davies. This is known as alpha stat concept. So alpha stat concept, what he told that there is based to define a partial pressure of a gas at its pH of electrical neutrality. That means any patient in our body we are or electrically neutral. So in our body, your pH or PN or electrical neutrality of pH is at 6.8 degrees centigrade. At 6.8 at 37 degrees centigrade, and this 6.8 PN is usually it is irrespective of the temperature that he has shown. That's why you are usually not using any temperature correction. Okay, standard base excess yesterday we have discussed. Standard base excess is we are checking the actual blood excess and we are checking the anemic hemoglobin. That means we are checking the hemoglobin to be 5 gram%. So this is just to rule out the buffering of extravascular fluid by hemoglobin. Hemoglobin also has a buffering capacity. We are just negating that. So we are using the standard base excess. Okay. So now few other things we just want to tell you. If you are having methylene blue you are giving in a patient with very severe shock, or vitamin B12, they can sometimes interfere with your saturation of oxygen. Anesthetic gases like halothane, nitrous oxide, isoflurane, they can also cause increased in PO2. Delay in analysis, very important. Your PO2 will be decreased, PCO2 will be increased, and pH is decreased. Already we have discussed. So there is some formulas given. Fall in PO2 will be 2 millimeter per hour at room temperature. It can be elevated if you have a high WBC count. Similarly, PCO2 increase will be 1 per hour, but it can also go up with elevated WBC count. pH fall will be around 0.02 to 0.3 unit per hour at 22 degrees centigrade. So these are the few formulas just to know if there is already some delay. Okay, another important thing, suppose you are taking blood gas in a patient who is in a very high altitude states, sometimes in a some catastrophe in the mountains and all those times, all those areas. If you are checking point of care device there, they can have low atmospheric pressure and low PO2. So you have to think of the altitude also whenever you are interpreting a blood gas. And sometimes in air ambulance and all, where you are transporting sick patients, the cabin is already pressurized, so atmospheric pressure is also high. In all those scenarios also, your PO2 and PCO2 might change. So in these scenarios, you have to keep in mind all these things. Okay, so how to correct the errors? This is from this book, this checklist manifesto, where the author has shown that all the complicated in the areas where there are complicated things, like complicated systems are involved, like in intensive care unit, several departments are involved, several machineries are involved. In all those complicated scenarios, the checklist sometimes will help you to prevent the errors. So this checklist, this is just like a demo checklist where you can see the important things you have to tick it, like clean the hands, check all necessary equipments is there or not, identified, put on gloves, identified location of radial artery. Next, these are the steps of Allen test. Next, how will you prepare the area? Prepare the area with alcohol wipe so that you won't miss any step. Use a heparinized syringe. Remove residual air from syringe. For credit, cap must be removed. Slightly adduct the arm, dorsiflex the wrist approximately 30 degrees inside the needle. Like these are the all simple steps, but most of the time during emergency and all, we might forget. So better to put a checklist in your emergency or in your ICU and you try to follow the steps. So these are important things, and you will know with that you might want to negate all these type of errors. So I just want to end by summarizing. First and important things to prevent the pre-analytical error is patient identification, followed by correct sampling techniques, using recommended sample containers and anticoagulants, and minimal time between sampling and analysis. This is the article from where I have taken the informations. Thank you all.
Thank you, Niladri, for Excellent talk. So a few questions came. Could you just please stop screen sharing and take the questions one by one?
Yeah.
So which syringe will use for ABG, 1 ml or 2 ml? Any literature, since center to center is varying. 1 ml or 2 ml syringe?
Okay. This will also depend upon
Niladri, you
your.
stop screen sharing, please. Yeah.
1 second. I'm not able to stop screen sharing.
Below the yeah. Fine, done.
Okay, sir has already said. Okay, yeah. So this is depending upon your center policy, but usually in small children and all, better to go for 1 cc syringe because they can have very little of blood volume, and if you want to go on taking 2 ml or more than that, they can have this arthrogenic anemia. But please remember,
Perfect.
1 ml syringe, you can have only 0.05 ml of heparin, not more than that.
Yeah. Then another is pushback. Like should not we push back the diluted blood?
No. Please don't do
That
that.
arterial line, no pushing, please.
No. These are all sources of infection. Please don't push that.
Yeah. An arterial line, if you push, there are a lot of things can happen. Like it can
Yes.
disturb the line, gangrene can happen.
Yes.
Are electrolytes reliable in ABG?
Yes. Electrolytes are
Yeah.
reliable.
Now the machines are very good.
Very
Like as
sensitive. And one important thing I forgot to mention about the calibration part. Whenever you are doing blood gas, in most of the machines, they have a regular calibration time. So suppose you are taking blood gas and that time the machine is calibrating. That time there will be inadvertent time it will be taken for the sample processing. So please ensure that that time the machine is not going for this calibration, and better to inform the technician beforehand that you are going to send the sample for blood gas.
yeah, many unit you have blood gas inside your PICU only, and the day-to-day whoever is working like residents or fellows, they are well versed with these machines. Or
Yeah.
if you have any difficulties, please don't hesitate to call the technicians rather than playing with these things.
Yeah. Okay.
And any other questions? I think all very nicely answered. So thank you, Niladri, for very important discussion, and all of these things which we have to remember when we are using for day-to-day basis. So the next talk will be by Dr. Subhadip Das sir. So Subhadip Das is in Narayana, and he is well-known intensivist in Bengal, Calcutta, as well as globally. So sir, Dr. Shubhadeep sir's topic is respiratory acidosis and alkalosis part, which we have not dealt till now. So the screen is yours, sir.
Thank you, Rohit, for that excellent. I hope I'm audible.
Perfect, sir. Screen is also visible.
Yeah. So in the next few minutes, I'll very quickly try to walk through some case scenario-based discussion on respiratory acid-based abnormalities. As I hear from Rohit that it has not been discussed so far, but I think from what discussions you had yesterday and so far, you have a fair idea of how acid-based abnormality. So with that background, it will be, I would believe, a fairly easy presentation for you, this thing, and I will try to make this a cakewalk for you. So as you might have already come across this table, I'm not sure. Let me just walk you through this table. So when we see a pH of less than 7.38, so this is adapted from a landmark paper which was published in NEJM, who defined acidemia as a pH of less than 38. Often find that pH of less being defined as acidemia, and as you have probably come across already, that the actual reduction of a pH is called acidemia, and an increase of pH is called alkalemia, and the process is called, the respective process is called alkalosis. So we will refer to acidemia as a pH of less than 7.38 here, but in textbooks, you would come across pH of less than 3.7 acidemia. So whenever you are finding an acidemia with a pH of less than 3.5, let's say, then the first thing as clinicians that we do is we look at the carbon dioxide and we look at the bicarb or the carbon dioxide are in keeping with this pH, then we define whether the acidemia is respiratory acidemia or it is metabolic acidemia, right? So in case of respiratory acidosis, let me say, in case of respiratory acidosis, the PCO2 will be high. You know that a normal PCO2 is generally around 35 to 45 is what we say of millimeter of mercury. If it is more than that, then that is an acidemia and respiratory acidemia. That we do usually as a clinician on the bedside is we try to see whether there has been a compensation for this acidemia. Now we know if the pH is reduced, if the carbon dioxide is increased, then the kidneys, they would try to retain bicarbonate and increase in carbon dioxide. Now, there is some formula to find out whether this compensation is adequate or this compensation is not adequate. Now, if you try to think as clinicians, what we do practically on the bedside, do we always try to do this mathematical calculation whether this compensation is appropriate or whether this compensation is not appropriate? We don't try to do, but then it's a good idea to have a basic understanding of how this formula look like. So if we know that this is a respiratory acidosis, let's say pH of less than 7.35, your PCO2 is high, the next step that we do is we look into the bicarb and we see if the bicarb is increased. Now we know that if the carbon dioxide is increased, what the kidneys try to do, they would try to retain the bicarb. So the formula is for every 10 millimeter increase in PCO2 above 40 millimeter of mercury, there is in acute respiratory acidosis a 1 millimole per liter increase in bicarb. If the bicarb increase is less than 1 millimole per liter, then there is additional metabolic acidosis. For chronic respiratory acidosis, as may happen with COPD, as may happen with bronchopulmonary dysplasia patients, in those patients, the kidneys get more time to compensate for this increase in carbon dioxide, and so the increase in bicarb is by 4 to 5 millimeter of 4 to 5 millimole per liter of bicarb, and if this is more than 5 millimole per liter, then there is an additional metabolic alkalosis. See, this is quite confusing. So practically, we do not do this very often on the bedside, but at least we try to figure out whether there has been a compensation, whether there has been an appropriate increase, whether there has been an increase in bicarb. And usually in a blood gas, in a blood, find that whenever there is a respiratory acidosis that is increase in PCO2, there is often an hypoxia. So by something called measuring the alveolar arterial oxygenation difference, you can figure out what is the hypoxia. I'm not going to go into the details of that, but that is something we can try and find out. Now, when the pH is more than 7.45, then we say that this is an alkalosis. When the carbon dioxide is less, that is less than, let's say, 45 or 40 millimeter of mercury, then we say this is probably a respiratory alkalosis. What is the body's response to that? What is the kidney's response to that? The kidneys will try to excrete bicarb. So just opposite of respiratory acidosis.
Sorry to
Yeah.
just some network issue is there, but I think just could you just switch off the video, your video?
Yeah,
because many I have no problem, but some audiences are
is this okay?
No, video is fine. Some Dr. Subhashi Saldar is taking that getting stuck, but it was fine. Sometimes with video it can cause. So please go ahead, sir.
Is this okay now?
Yeah, fine, perfect.
Okay. Okay, I'll just go ahead. So in respiratory alkalosis, where the PCO2 is reduced, what will be the body's response? The body's response will be to reduce your bicarb. So for an acute respiratory alkalosis, what happens is there are 2-point reduction in bicarbonate for every 10 millimeter reduction on PCO2 below 40 millimeter of mercury. And if this reduction is less than 2, then there is an additional metabolic alkalosis for a then kidneys get more time, so that there is a more reduction of bicarb around 4 to 5 points below 4 to 5 points for every 10 millimeter reduction of PCO2 below 40 millimeter of mercury. If the reduction is more than 5, then there is additional metal. I always find this very confusing. So practically, I don't really try to find out whether there is a compensated and whether the compensation is full or whether the compensation is partial. I think it does not add to much of practical value, but it's always a good idea to have a fair understanding of what do you mean by fully compensated and what do you mean by kind of uncompensated gases. And at the same time, when you have a respiratory alkalosis, then you can have hypoxia also. And as I have mentioned already, by looking into the alveolar arterial oxygenation difference, what may be the cause of this hypoxia. So with that background, let us look into our first case scenario. So we have a 7-year-old boy who is a known asthmatic and was rushed to the PICU. He has a severe attack of acute asthma that was triggered by exposure to a pollen. And despite giving repeated bronchodilators, the child struggles and there is marked dyspnea, audible wheezing, retractions. And when you examine the child, you find that the child is using accessory muscles of respiration. There is decreased oxygen saturation of 89% in room air. You do an ABG and you find 7.25, PCO2 is 60, bicarb is 24. So what is your interpretation? Let me quickly walk you through the gas. Let me quickly show you the gas once more. The pH is 7.25, PCO2 is 60, and bicarb is 24. So what is this? We see that the first step is the pH has been reduced. The pH is less than 7.35. So this is an alkalosis. This is an acidosis, right? And is the carbon dioxide in keeping with acidosis? Yes, the carbon dioxide has been increased. It is more than 40 millimeter of mercury. So there is a respiratory component. Let's say this is a respiratory acidosis. What has happened to the bicarb? Has the bicarb increased appropriately? The bicarb has not increased appropriately. What is the normal reference range of bicarb? It's between 22 to 28. The bicarb here is 24, right? So what happens is this elevated carbon dioxide, we know that this is a patient of acute severe asthma. So the patient is not able to expire the entire amount of air out of the lungs in carbon dioxide. So this is leading to respiratory acidosis. But the kidneys have not started the process of retaining bicarbonate yet. So the process is acute because as we would see, subsequent kidneys take some time. So bicarbonate at the bicarbonate is normal shows that this is an acute process. In the initial part, there may be some buffering from the cells and from the bones, but we do not see that kind of buffering. So what is this? This is just a simple respiratory acidosis without any compensation, right? Let's look into the next gas. So this is a 3-month-old infant. He develops increased work of breathing, has got a background of prematurity and chronic lung disease. And because of this prematurity and chronic lung disease, he is on some home medications, which are hydrochlorothiazide and spironolactone. Now let's see. The patient was shifted to the PICU and we did a capillary gas. So what does the capillary gas look like? pH is 7.32, PCO2 is 70, and we see a bicarb level of 37. Now, what do you think is the abnormality in this patient? Is this metabolic alkalosis with respiratory compensation? Is this a metabolic acidosis with respiratory compensation? Is this a respiratory acidosis with metabolic compensation? Or is this a respiratory alkalosis with metabolic compensation? I will quickly show you the gas once more. I'll here just pause for a few seconds and give you some time to just quickly let me know what is this gas like. So you can quickly reply me on the chat box. What do you think is the abnormality?
See, What is the answer? Is 3. Chronic respiratory acidosis with compensation by Dr. Pradeep. Primary respiratory acidosis with fluid. Option
Great.
3 people answered, sir.
Great, great. So that is fine. I see there are 90 participants. So I hope that some have got the answer right. And for the ones who did not get the answer right, so what could have been the primary abnormality here? This could be metabolic alkalosis due to diuretics. We know that the diuretics cause metabolic alkalosis. Is this a metabolic alkalosis because the patient was on some diuretics like chlorothiazide and spironolactone? And was this a respiratory compensation of that? Or was it a chronic lung disease, an acute and chronic lung disease with carbon dioxide retention with metabolic compensation? Now, the pH was less than 7.35. We saw the pH was 7.32. The primary process, therefore, must be an acidosis here, because usually the compensation process cannot overshoot a primary disorder, right? So the physiological principle here is the presence of a primary disorder drives compensation. However, as your pH gradually becomes normal, the stimulation for this compensation process decreases. So, in response to a primary acidosis and alkalosis, body does try to compensate, but compensation is usually incomplete and the pH never normalizes. So, if we see a pH of 7.32, probably an acidosis and not an alkalosis with a compensation, right? Now, for a metabolic process, what will happen? There is respiratory compensation, right? And respiratory compensation is very rapid, within minutes to hours. Whereas for a primary respiratory process, the renal compensation takes hours or days to be completed. And here, what we find is a metabolic compensation. Here, what we find is the pH was 7 with a carbon dioxide, which was more. So this was a respiratory acidosis and there was a metabolic compensation. So the metabolic compensation gives us a clinical clue that there was an element of chronicity. Of course, we know that bronchopulmonary dysplasia, prematurity, chronic lung disease, all these are chronic procedures. Had the infant been hypercapnic and there would have been a normal bicarb level. See the bicarb level. Let me once more go back to the clinical picture. The bicarb level was 37. Had the infant been just hypercapnic with a normal bicarb level, then this would have been much more alarming for me. This gas would have given me a clinical clue that this was much more alarming, because this would have been an acute process, right? So here that the bicarb has increased a bit. Again, I'm not going to go into details whether this is appropriate or appropriate compensation or this is not fully compensated. And those kind of discussions I'm not doing. But there has been some compensation. So this gives me an idea that there has been a chronicity. If there was bicarb was normal, then it would have been told me that this was an acute process. So it would have been much more alarming. Yeah. Was clear. With that, we go into our third clinical scenario. So a 16-year-old girl presents to the emergency department with a panic attack. We see that adolescents often present in the emergency department panic attacks, and the sorry for the gender confusion here. Her symptoms included shortness of breath, palpitations, chest pain, diaphoresis, and facial numbness. We see an ABG where we find the pH was 7.53, PCO2 was 25, and bicarb was 20. Now, how do you interpret this blood test? Again, I'll quickly give you a few seconds and then I'll run you through this explanation. You can just quickly type it in a chat box. How do you interpret this blood gas? All right. So my interpretation is this is an acute respiratory alkalosis due to panic attack, right? So going back to the first couple of slides that I showed, where I showed you that for every 10 millimeter reduction of PCO2, bicarb would reduce by 2 milliequivalent. Therefore, for a PCO2 of 25 millimeter of mercury, now how much is the reduction of PCO2 then from 40? The reduction is 15. So the expected bicarb is, let's say, 24 minus 1.5 into 2, right? So that will be 21. And here what we see the bicarb is 20. So it's almost like that. right? So this is an acute respiratory alkalosis, and there has been an appropriate metabolic compensation. Okay. And whenever we see an alkalosis, as clinicians and particularly as beginners, we often tend to ignore respiratory alkalosis because we think that that's a benign problem. But we have to remember that alkalosis can be actually very, very ominous. And there are certain things that I would like you to remember always, that acute and rapid respiratory alkalosis can lead to confusion, can lead to lightheadedness, cramps, numbness of the extremities around the mouth, and circumoral numbness also. And rarely, patients may develop seizures. And what does it do? It would reduce your cerebral blood flow. There is cerebral vasoconstriction, right? So therefore, you can have all these central symptoms. And also, alkalosis can shift the oxygen hemoglobin dissociation curve to the left, and there is less amount of oxygen available for the tissues to extract, and it can inhibit the respiratory drive. It can also induce hypokalemia and hypocalcemia. Acute respiratory alkalosis is also in severe cases associated with atrial and ventricular tachyarrhythmias. And however, we do not correct the severe hypocapnia rapidly, because what it does is, if you rapidly correct the hypocapnia, then it can again cause a rebound, very rapid cerebral vasodilatation and increase in intracranial tension. Now, our next patient is a patient with myasthenia gravis who presented with myasthenia gravis crisis and now is on mechanical ventilation. And recently, he has been suffering from nausea and vomiting. His medications at home includes furosemide, and initial ABG showed on mechanical ventilation a pH of 7.33, a PCO2 of 68, and a bicarb of 35. Again, few seconds for you to answer, and then let's walk into the explanation. All right. So my interpretation of this gas is this is an acute respiratory acidosis. Yeah, this is an acute respiratory acidosis due to myasthenia gravis. Now, what is the metabolic compensation? What is the expected metabolic compensation for this? Again, let's go back to the gas. The pH was 7.33, PCO2 was 68, and bicarb was 35. So going back to my first slide where I showed you what would be the appropriate metabolic compensation for a respiratory acidosis. So going by that formula, here the metabolic compensation should result in a bicarb of 27, right? With a maximum increase of 30. Here the bicarb is 35. So I'm not going to go into the formula, but if you just put all the numbers in that formula, then you would find that the bicarb expected is 27 and it could maximum go up to 30. But here we find that. So is this appropriate compensation? No. This is an overcompensation. So what it could be due to? This probably is due to the recent history of vomiting and use of furosemide also. So there has been a volume metabolic alkalosis. So this is acute respiratory acidosis plus there is a component of metabolic alkalosis. And similar to the alkalosis, we know that acidosis can also be associated with several dreadful things. Acute respiratory acidosis can cause dyspnea, confusion, psychosis. This is because of carbon dioxide narcosis, and hypercapnic encephalopathy is very well-known thing, which can progressively result in a coma. High CO2 can also cause cerebral vasodilatation. As I told you, can increase in intracranial hypertension. In severe cases, there may be papillary edema, and severe hypercapnia can cause cardiac arrhythmias, low cardiac output state, and hypotension. Let's go to the fifth case scenario then. An infant was born at 37 weeks of gestation and now is 2 hours old. And the findings are as follows. He's very tachypnic with a respiratory rate of 94. The heart rate is 162. The temperature is 36.5. There is some grunting with moderate retractions. We do a capillary blood gas, which shows a pH of 7.3. PCO2 was 56. Bicarb was 26. And PO2 was 40. So how do you interpret this gas? On a Zoom, actually, I find it sometimes very tricky to run a case-based scenario kind of presentation because it's not interactive.
So people are answering, sir.
But anyways,
Nicely they're answering. Compensated respiratory acidosis. Respiratory acidosis with metabolic. Dr.
That's the
Subhash.
answer, right? So yeah.
Yeah.
So the pH, the first step. I hope that yeah. So Dr. Suresh has already run you through the steps of interpreting a gas. The first step, the pH is low, so it indicates an acidosis. Next step, the PCO2 is in keeping with the pH. The PCO2 is high, so it's a respiratory problem. The metabolic compound, bicarb. The bicarb, how much is it? Bicarb is 26. The normal reference range of bicarb is 22 to 28. So the bicarb here is normal. So there has not been a compensation. So the kidneys did not get, I told you that the kidneys need some time for compensation. So here the kidneys did not get adequate time. This is uncompensated respiratory acidosis is an acute problem. The oxygenation here is more or less adequate. So the intervention, we know, treatment, improving your alveolar ventilation. You might consider nasal CPAP, positive pressure ventilation, whatever the child needs. Now going to a sixth case scenario. A premature infant on mechanical ventilation for respiratory distress. You see the findings, you see the settings on ventilator. The respiratory rate is 30, your PIP is 19, PIP is 5, and FiO2 is 40%. The infant has lost weight and serum sodium is 140, age of 7.28, PCO2 is 49, PaO2 is 56, and bicarb is 18. Explanation?
So answer is Dr. Kanouri answered metabolic acidosis with added respiratory acidosis.
Okay, that's great. Let's see. Low. So this is acidemia, right? No confusion. PCO2 is high. So this is a respiratory problem. The metabolic component, is it in keeping with acidosis? Is it compensating for the CO2? No. There metabolic problem, as you rightly said. So there is no compensation. The pH is not normal. The PO2 is adequate. So this is uncompensated mixed respiratory and metabolic acidosis. So, what are the interventions? You might consider increasing your ventilation by increasing your ventilatory rate or some other maneuvers. You might consider giving some volume to correct the hypovolemia, which may be the cause of this metabolic acidosis. All right. Moving into another case scenario. Here we see a 12-year-old patient with cystic fibrosis, which is a chronic problem and now presents for a routine follow-up. And despite respiratory therapies, the patient has chronic productive cough and exercise. One ABG, which shows a pH of 7.38, CO2 is 58, bicarb is 31. So what is the explanation here? So there is elevated CO2 and elevated bicarb. This is a chronic respiratory acidosis. Is there a compensation? Yes, there is some compensation. Again, I told you that usually on the bedside, at least what I do as a clinician, I look into the compensation. Yes, there has been a compensation, but usually I do not look into whether there has been an appropriate compensation. Usually I do not do that all. This is cumbersome, and two is that I think that it adds very little to our clinical judgment. But yes, here at least it's important to realize that there is some compensation. So the patient's chronic lung disease leads to impaired gas exchange and carbon dioxide retention. The kidneys here is trying to compensate for that, and there has been an increase in bicarb. So the management here is aggressive airway clearance, antibiotics, and possible oxygen for the underlying lung disease. All right. So I discussed about seven case scenarios, and this is something which Rohit asked me to. So this is a blood gas which Rohit has shared with me and just wanted me to explain on this SO2 part, which is the saturation of hemoglobin. So here what we see is a pH of 7.3, PCO2 of 26, bicarb, corrected bicarb of 14. So this is a metabolic acidosis. There probably is some respiratory compensation for that. And the saturation is 87%. The PO2 is 55. Now, all of you, are you clear on what is PO2 and what is SO2 and how are these two values interlinked? So PO2, as we know, is the partial pressure of oxygen in blood. Saturation of hemoglobin, how much hemoglobin is saturated with oxygen, right? So basically, the PO2 SO2 relationship gives us an idea about the oxygen delivery to the tissue. Now, we know that the fundamental concept of stabilizing any sick patient in ICU is ensuring adequate oxygen delivery. And oxygen delivery is determined by the total oxygen content and the cardiac output, right? And what is the oxygen content? The oxygen content is given by the formula as hemoglobin, how much hemoglobin is saturated, multiplied by 1.34 plus 0.003 times PaO2. So, under normal circumstances, the PaO2's contribution to oxygen saturation is very, very low, right? Very, very low. Unless a patient is extremely anemic. And this we know from our physiology days, how the oxyhemoglobin and PO2, they are related. We can see that this is a sigmoid shaped curve, and the oxygen saturation, the PO2, as the partial pressure of oxygen increases, the oxygen saturation increases gradually up until a certain point. But beyond a certain point, however may you increase your partial pressure of oxygen in the blood, the oxygen saturation of hemoglobin does not increase much. It flattens out. And then there are some factors which can push your oxyhemoglobin dissociation to the right. We know that reduction of pH, acidosis, increased diphosphoglyceride, increase of temperature can shift your oxyhemoglobin dissociation to the right. So more oxygen will be available for utilization by the body level, more tissue oxygen extraction, and there are some factors like increase of pH, reduction of DPG, reduction of temperature, which can push your oxyhemoglobin dissociation curve to the left. So there is less oxygen extraction, there is less amount of oxygen extracted by the tissue. So this is how your PO2 and SO2 is related. We often get confused. There are usually in our in the beginning of our training days. So it's good to have a clear idea of how SO2, how oxygen saturation, and PO2, partial pressure of oxygen in the blood, they are related. Okay. So my last slide is, let's recapitulate. How do you interpret the gas? First of all, we look into the pH, whether it's an acidosis, whether it's alkalosis. When you find that there is an acidosis, then you look into the carbon dioxide and the bicarb. But in keeping with the acidosis, if the carbon dioxide is in keeping with your acidosis, then it's a respiratory problem. If the carbon dioxide is low, then it's a respiratory alkalosis. If the carbon dioxide is high, respiratory acidosis, right? And then after that, you look into your bicarb, whether there has been a compensation for that, and then you try to remember this formula, whether the compensation is appropriate or not. And I'm not going to discuss about the standard basics, which I think has been dealt in details. I was looking to all the discussions, and that has been dealt in details, I think, in the last 1.5 hours. So with that, I would end my presentation. If there's any question, I'm happy to take that up now or at the end of this session. Thank you.
Thank you, Dr. Subhadeep, for excellent session. So I'll hand over to Niladri for Q&A. Any questions are there, Niladri?
No, sir. No question. Anyway, whenever they come, I think we can take at end of the session.
Okay. Thank you very much, Subhadeep. Could you just stop screen sharing? Yeah. So after this session, we are moving towards our last session of this 2 days academic, and the next session will be on metabolic alkalosis. So we have dealt with all the possible acid-base disorders. For this last session, we will have Dr. Mohammad Ali, who is one question came. We will answer on the chat box. So Dr. Mohammad Ali did his MD from PGI Chandigarh and DM Pediatric Critical Care from PGI Chandigarh. Right now he is there in Durgapur and as well as in Medical College, Kolkata. So Dr. Mohammad Ali, shall I share screen, Mohammad Ali?
Yes. Please you share my screen.
Yeah. So Niladri.
So am I audible to all of you?
Yeah.
Am I audible?
Yes, sir. Yes, sir. You're audible,
So
sir.
can I start?
Yeah, please, sir.
Okay.
So,
Thank you, West Bengal Academy.
So, Dr. Ali,
Hello?
you just switch off your videos for better network. I think you are outside. So please switch off your video. Then you will get your audio better.
So, now, okay. Now, is it audible now?
Yeah, audible. But you switched off your video. Yeah,
I have switched
perfect.
off my video.
Yeah, perfect.
Okay. So, thank you to all of you. And special thank to West Bengal Academy of Pediatrics and West Bengal Pediatric Intensive Care Society for giving me this opportunity to talk in front of all of you. So I will be talking about the metabolic alkalosis. So I think this is the in this talk, I will be briefing about the definition, the renal acid-based physiology, and the pathogenesis of metabolic alkalosis in various case scenario, and etiology and how to evaluate the case with metabolic alkalosis. And briefly, I will discuss about the management. So the next slide, please. So the metabolic alkalosis, actually, it is, I think it is the most ignored part in the blood gas analysis. So when the pH is more than 7.4, we become so relaxed that it is absolutely normal, and we usually hardly do any intervention for that. But metabolic alkalosis itself is a significant problem. And if you see the prevalence of metabolic alkalosis, we'll find that the metabolic alkalosis is the most common blood gas abnormality in ICU patients. And the prevalence is reported up to 70% of the patients, and the highest prevalence is seen in cardiac ICU patients. So by definitions, metabolic alkalosis should have three criteria. One is pH that should be alkalemic, that is pH more than 7.45. Bicarbonate should be more than 26, and you should have high CO2. And in metabolic alkalosis, the compensations will be with the respiratory. So you know these things because it is the last presentation. So you are familiar with these compensations. So body will compensate the high carbonate, bicarbonate, and there will be production of the CO2 from the
Hello, Ali, sir.
hello. Yeah, am I
Yeah.
audible?
Yeah. You're audible now, sir.
Okay,
Please, sir.
some problem. There is some problem with the network. Okay.
I think, sir,
So in metabolic alkalosis, you can, yeah.
the last part of the previous slide, I think
Okay.
they have missed, sir.
Okay. So metabolic alkalosis can be divided in the three categories, like mild if the pH is up to 7.5, moderate if the pH is up to 7.5 to 7.55, and severe if the pH is more than 7.55. But metabolic alkalosis also is associated with the mortality if the pH is more than 7.55, and the mortality can be as high as 85%. Next slide, please. So in compensations, metabolic alkalosis, there will be compensation with the respirations. So there are so many formula that we are aware about the metabolic alkalosis compensations, like expected PCO2. The most commonly used formula is 40 plus 0.7 into bicarbonate minus 24. But one author has evaluated there are around 30,000 blood gas. 30,000. I am repeating, 30,000 blood gas, and he has evaluated all these formula that I have mentioned in this graph. And he found that the best fitted formula will be the 0.8 into bicarbonate plus 20. That will be the best fitted model. And what he found that another is the simplest formula, that the expected PCO2 is bicarbonate equal to plus 10. That is equally that correlate with the best fit model. So whatever the formula that you use, if you see this formula perform pretty well if the CO2 is up to 30 to 50, but if the CO2 crosses more than 50 or 55, then the relationship is not so strong. So this is very important. So if the CO2 is very high, then the relationship between the bicarbonate and the CO2 will be, that should not be so much of precise. So next slide, please. So in this case, I will be taking out the first case. This is the 4-month-old infant who is having bronchopulmonary dysplasia and having chronic CO2 retention and receiving furosemide and metazolam therapy. And one blood gas was done that is showing pH of 7.43, PCO of 58, PO of 68, and bicarbonate of 36. Sodium is 137, potassium is 2.4, that is low, and chloride is 86, that is also low. So you can guess what is the probable metabolic problem, acid-base disorders of these patients. So clearly the pH is more than 7.4, so it is obviously it is alkalosis. And if you see the bicarbonate, that is bicarbonate is high, and the CO2 is also high. So it is obviously it is a metabolic alkalosis along with hypokalemia and the hypochloremia. So hypokalemia and hypochloremia that we will be discussing in the later on. Next slide. So this case 2 is a little bit difficult. Try to understand. This is a 16-year-old girl who is brought to the emergency department by her parents, who are concerned because she has extremely depressed and recently threatened suicide. And tonight they found her vomiting and just not acting well. And laboratory evaluations in emergency, the sodium is 144, the potassium is 4.3, and the chloride is 100, bicarbonate is 24, arterial pH is 7.4, and PCO is 40. So if you see the blood gas, you will find that is the absolutely normal blood gas. The pH is 7.4, CO2 is 40, and bicarbonate is 24. But if you closely look at this blood gas, if you find out the anion gap is around 20, if you calculate 144 minus 100 minus 24, the anion gap will be around 20. So this is not obviously, it is a normal blood gas. So if there is hidden anion gap, then absolutely there is some problem. So if you calculate the delta gap, that is the delta bicarbonate gap minus delta anion gap minus delta bicarbonate gap, that will be 8. So if you see this blood gas, it is actually saying metabolic acids as well as metabolic alkalosis. So whenever see the blood gas, we have to sometimes see very meticulously, otherwise we will miss the metabolic alkalosis. Next slide, please. So in metabolic alkalosis, we have already discussed. So there will be respiratory compensations. Respiratory compensations because the metabolic alkalosis, the respiratory center will get depressed and there will be hyperventilations. So after a certain point of time, because of hyperventilation, there will be hypoxia. So hypoxia will stimulate the respiratory center further. So that's why your CO2 will not go as high as is possible. So there will be some checkpoint. When the hypoxia will ensure, then your respiratory dive will be more. Other than that time your CO2 will get out. Like if you have the CO2 is very high, that is CO2 is more than 60, you can have two conditions. One is coexistent respiratory acidosis or severe metabolic alkalosis that is associated with cross-anion effect. That means in that case, there is severe loss of the chloride and the bicarbonates go above the chloride level, and there will be severe respiratory depressions with respiratory muscle weakness, and that time your CO2 may goes more than 60. Next slide, please. So metabolic alkalosis is not like a benign procedures. It has lots of systemic problems. One is the hypoventilation that is associated with hypoxia and the hypercarbia. Second, there will be more of loss of hypoxic pulmonary vasoconstrictions that will be associated with the VQ mismatch. There will be a shift of oxidation curve towards the left side. So there will be more affinity of the hemoglobin to the oxygen. So less oxygen delivery to the tissue. There will be myocardial depressions and associated volemia. All this will cause tissue hypoxia. Along with alkalosis will cause vasoconstriction to the coronary arteries as well as the cerebral artery, and will cause tetany, seizures, delirium, coma, and the arrhythmias. And metabolic alkalosis is partially associated with hypokalemia or worsening with hypomagnesemia, hypophosphatemia, and reduced ionized calcium. So metabolic alkalosis is not a benign problem, and is lots of systemic complications. And it has actually 3 phases. One is the initiation phase, that is associated with the loss of your acids or the gain of bicarbonate in your body. So the acid may be lost through your GI tract or through your kidney, and you can have your more bicarbonate like alkali load in your body through the ingestions or infusions. That will start the process and tilt the balance of acid and the bicarbonate load in your body, and it will start alkalosis process. So this process is actually maintained even the primary illness is actually abated, but still the alkalosis may continue because of the associated with hypovolemia, your low GFR, hypokalemia, hypochloremia, hyperaldosteronism, and the hypercapnia. This maintenance phase I will be discussing later on, because this is the main part of management of the metabolic alkalosis. So we have to find out the maintenance factors like hypovolemia, hypokalemia, hypochloremia, hyperaldosteronism, and hypercapnia, and we have to treat these things to treat your metabolic alkalosis. And the third phase is the resolution phase, when you correct these electrolyte problems, your volume status, and you treat the primary cause, the thing is get over. Next slide, please. So, before going to the further discussions, I will first discuss about the briefly about the bicarbonate handling of the kidney. So you know the proximal convoluted tubules actually absorb 80% of the bicarbonate, which is secreted through your with your glomerulus, and around 10% or 15% get absorbed in the thick ascending loop of the Henle, and rest 3 to 5% get absorbed in the cortical collecting duct. The only site where the bicarbonate is lost through the kidney is the cortical collecting duct, and that is the intercalated B cells or non-A, non-B intercalated cells through the Pendred channel. So you should remember this channel, the Pendred channel. That is the only channel through which your bicarbonate is get lost in the urine at the exchange with the chloride, and otherwise your proximal convoluted tubules, your loop of Henle, and the collecting ducts all reabsorb your bicarbonate. Next slide, please. So in proximal convoluted tubules, on the luminal sides, there is two channels. One is sodium potassium ATPase, one is sodium hydrogen exchange channel, and another is hydrogen ATPase channels. And on the interstitial side, that is the blood vessel side, there is two channels. One is sodium potassium ATPase, and another is sodium bicarbonate co-exchange or co-transporter. So what happened, because of the sodium that is get absorbed from the cells to the blood, inside the cells there is low sodium. So this sodium get absorbed from the lumen through this hydrogen sodium hydrogen exchanger, and with the exchange of the hydrogen ion into the lumen. To just maintain the electrical neutrality, when the sodium, the positive ion, is getting from your lumen inside the cells, your lumen is getting more negative. So to maintain the electrical neutrality, your hydrogen ion will get excreted through your hydrogen potassium ATPase, ATPase pump, as well as your sodium hydrogen exchanger. So I think you can understand this portion. So basically it is the sodium potassium ATPase which create the negative sodium balance inside your cells, and because of that, sodium from the lumen will get inside your cells. So the lumen will become more negative. So hydrogen will get excreted from the cells inside your lumen, and this hydrogen ion will bind with this bicarbonate inside the cells, and it will produce the bicarbion. That bicarbonate will get absorbed along with your sodium. That is the sodium bicarbonate co-transporter. So this is, I think, very important slides. We'll be talking later on about this slide. So please try to understand on this slide. And on this, like this portions, there is two important pathophysiological mechanism that is associated with alkalosis. One is post-hypercapic alkalosis. In post-hypercapic alkalosis, there is lots of CO2. That CO2 get dissociated in the blood, and they produce more of bicarbonate and hydrogen ion. That hydrogen will add as well as the bicarbonate that is more in the proximal tubules and the lumen, that will be more absorbed in your blood. So because there is abundant bicarbonate and the hydrogen ion inside the body, so there will be more absorption of the hydrogen, bicarbonate ion, as well as the excretion of the acid through the kidney. And in hypovolemia, there will be more sodium absorptions, and you know the sodium will get absorbed along with the bicarbonate, so there will be more bicarbonate absorptions. And as there is low hypovolemia with low GFR, so your ultimate bicarbonate excretion through the body will be less. So because of that, you're in hypovolemia, you will have metabolic alkalosis. Next slide, please. So in the next slide, in the cortical collecting duct, you will how the bicarbonate get absorbed and in the intercollected B cells, how the bicarbonate get excreted in the lumen. So that we will be discussing. So in cortical collecting duct, there are three important cells. One is the principal cells, and another is intercollected A cells and the intercollected B cells. So principal cells and the intercollected A cells, they are associated. They are actually helping us to absorb sodium and the water from the lumen. And the intercalated B cells or non-A, non-B intercalated cells, they are actually working as like a chloride and bicarbonate, they excreted bicarbonate in the lumen at the exchange of chloride absorptions. So what happened in principal cells, the sodium potassium ATPases, just like above slide, the sodium potassium ATPase, the sodium will get absorbed from the cells inside the blood. So your cellular sodium will be less. So the sodium from the lumen will get inside the cells through this epithelial sodium channel. That is the site of mineralocorticoid activity. The epithelial sodium channel, the cells sodium from the lumen will get inside your cells. But to maintain the electrical neutrality, your potassium will get out from the cells inside into the lumen. But still, the electrical neutrality will not be maintained, and there will be lots of negative charge inside the lumen. So to maintain that negative charge, the hydrogen ion will get excreted to the lumen through the intercalated A cells, the hydrogen potassium ATPases channel. So because of this hydrogen as well as the potassium will get excreted through the kidney, and there will be absorption of the sodium as well as the water. So this is the basic mechanism of the mineralocorticoid hormone, and that we'll be discussing later on. And in this hydrogen ion, which is get excreted into the lumen, they will bound with the bicarbonate ion that is excreted through the pendrin receptor, pendrin channel in the interconnected B cells. Then there will be production of the bicarbonate CO2 as well as the water, and that CO2 will get inside the principal your intercalated A cells, and they will convert it to the bicarbonate, and that they will get absorbed in the blood. And the rest of the hydrogen ion, they will bind with the phosphate as well as the ammonia that is also produced in your intercalated A cells in the cortical collecting duct. They will bind with the ammonia as well as the phosphate, and they will get excreted to the kidney. So hydrogen are ultimately excreted to the kidney in the form of the ammonium as well as the phosphate as well as the hydrogen per se. So these are the two important slides that is very important to understand. Please try to concentrate on this slide. So in proximal convoluted tubules, or distal tubules, your cortical collecting ducts, every sites, all the sites, your hydrogen ion and the potassium ion get excreted into the your lumen, that and more bicarbonate absorptions. And this is the only challenge, that is the pendrin that actually excrete the bicarbonate ion from the body. Next slide, please. And another important thing is the kidney is the important site of ammoniogenesis. So ammonia transport and the excretion through the kidney is very complex. So in kidney, the proximal convoluted tubules as well as the cortical collecting duct, these cells actually produced ammonia from the glutamate. So if you see the right hand side of the pictures, your glutamate will get dissociated, and they will produce 2 ammonia ion as well as 2 bicarbonate ion. So this ammonia that I have discussed just previous slide in the proximal the intercalated A cells, they will bind to the hydrogen ion in the lumen, and they form the ammonia, and they will get excreted through the kidney. So in proximal convoluted tubules, there will be productions of the ammonia in the lumen. That ammonia will come into the Henle loop of the Henle, and in the ascending loop of the Henle, there is sodium chloride to sodium potassium 2 chloride channel, that is NKCC channel, where the ammonia will get absorbed from the tubules, and they will come to the interstitiums. And from that interstitiums, again, they will get inside the in the cortical collecting duct. They will bind with the hydrogen ion that we have already discussed previous slide, and they will be excreted through the kidney. So the ammonia transport in the kidney is very complex, and it is complicated. Next slide, please. So if you see the etiological classification of the metabolic alkalosis, this metabolic alkalosis can be because of the hypochlorite depletion of the body or the potassium deficiency. These are the two major mechanisms. So chloride get depleted because they lost from the GI tract. That is because of the vomiting. That may be because of the mechanical drainage, NG tube, diarrheal state, few rare diarrhea conditions. And in kidney, if you use the diuretics, and if it can get excreted through the like sweat, like cystic fibrosis, or in post-hypercapnic state. Another important cause is potassium depletion that is seen in Bartter syndrome, Gitelman syndrome, excessive laxative use, and the clay ingestions. Next slide, please. Another state is the mineralocorticoid excess. Like if we have already discussed, if you have more mineralocorticoid, there will be more sodium absorption in the cortical collecting tract at the expense of the loss of potassium as well as the hydrogen ion. So it could be because the primary hyperaldosteronism because of the tumor or other things, or it could be because the apparent mineralocorticoid excess activity that is due to the enzyme deficiency or few drugs, or it is because of some syndrome that is the Liddle syndromes. In Liddle syndromes, it is the autonomic dominant type of disease, and that is associated with the activation of this epithelial sodium channel. That actually absorb more of the sodium at the expense of the potassium as well as the hydrogen ion. And there may be secondary aldosteronisms. Another is a hypercalcemic state, and few antibiotics like a penicillin group of antibiotics, more of bicarbonate injections like milk alkali syndromes, or hypovolemia that is very common in our pediatric ICU. Next slide, please. So with this background, we will again come to another case scenario. That is a 10-year-old boy who is admitted for the management of the hypertensive urgency. The patient mother and the grandmother were hypertensive, and patient's mother had chronic kidney disease with very low eGFR. And on examination, says hypertensive, otherwise systemic examination is unremarkable. Investigation shows alkalosis, that is pH 7.5, bicarbonate of 32, sodium is 138, potassium is 2.1, and chloride is 78. And if other investigation that was shown, both the renin activity as well as the aldosterone activity is the lower than the reference range. So can you guess what is happening? Sometimes this metabolic alkalosis point towards your diagnosis. So if we analyze this case, we will have like the metabolic alkalosis as well as hypochloremia and the hypokalemia, and that is associated with the hypertension, and both renin and aldosterone level is low. That means if there is hypertension with hypokalemia and alkalosis, that is a state of mineralocorticoid excess. But in our aldosterone level as well as the renin level, both are low. That means it is like the mineralocorticoid is actually the situation is like excess mineralocorticoids, but the mineralocorticoid activity is actually low. So it is because of the Liddle syndrome, that is activation of the epithelial sodium channel that actually absorb more of the sodium. So that causes the state of hypervolemia leading to hypertension, and because of the hypervolemia, your aldosterone and renin level gets suppressed. So I think you get some idea that metabolic alkalosis sometimes may be the diagnostic. So if you go to the pathophysiology of the Liddle syndrome, I have already discussed these things. So it is the problem with the epithelial sodium channel, epithelial sodium channel. So we have already discussed so many times. Next slide, please. Next case 5. Like this is another case scenario. A boy who is 6-month-old presented with failure to thrive, constipation, and the polyuria. And on examination, he is malnourished, but blood pressure is towards the normal or high normal side. Investigation showed sodium of 135, potassium is less, hypokalemia, hypochloremia, and there is metabolic alkalosis with bicarbonate 42. And here your renin and aldosterone level is very high. So it is a state of hyperaldosteronism. But the situation is hypochloremia, hypokalemia, and there is failure to thrive as well as the polyuria. So there will be some problem with the relative blood effect. So it is actually the sodium Bartter syndrome. And the Bartter syndrome, it is just like it is the main effect is on the sodium, potassium, and 2-chloride channel, that is NKCC channel. It will show the effect just like the furosemide, the furosemide or the diuretic that you use. So because of that, your sodium, potassium, and the chloride will not get absorbed. So there will be state of hypovolemia and there will be hypochloremia. and there will be activation of this renin-angiotensin system in the aldosterone systems. It will cause alkalosis as well as the hypokalemia. So these things I think you will get in your textbook. So this metabolic alkalosis, hypokalemia, and a state of hyperaldosteronism with polyuria and like failure to thrive, it shows the patient is having Bartter syndrome. Next slide, please.
Hello.
Dr. Rohit. Yeah.
Okay. Okay.
Next slide, please. Another syndrome is the milk alcohol syndrome. That is actually we found in the like earliest age, where the patient was prescribed with like antacid as well as your calcium containing like a salt as well as the milk, and that is associated with the hyperkalemia, hypercalcemia, metabolic alkalosis, and the renal insufficiency. So this hypercalcemia actually inhibit your renal outer membrane potassium channel in the proximal convoluted tubules, and ultimately it inhibits your sodium potassium 2 chloride channels. So that is actually like the effect will be just like your Bartter syndrome or the use of furosemide. So another case scenario is the 3-month-old boy who presented with recurrent vomiting, failure to thrive, there is weight loss, and was admitted and treated for severe dehydrations on day 30 of life. Now, but baby is facing urine adequately. On examination, he is otherwise malnourished. Vital sign is more or less acceptable. On investigation, he is having severe metabolic alkalosis with sodium of 121, hyponatremia, hypokalemia, and the hyperchloremia. And this is the X-ray that is showing like distended stomach. So the diagnosis is very clear. That is the state of hypertrophic pyloric stenosis with hypochloremic, hypokalemic metabolic alkalosis. So next slide, please. So this the pathophysiology of gastric alkalosis, that is the any loss from the stomach, like that could be because the hypertrophic pyloric stenosis or angiaspirate or vomiting, anything. So the parietal cells secrete the hydrochloric acid into the lumen. At the same time, they produce the bicarbonate ion. And when the hydrochloric acid coming down to the duodenum, where it binds with the pancreatic juice that contains the more of the bicarbonate, and what they get actually neutralized. But ultimately, there is no bicarbonate loss. But if the hydrochloride get excreted from your body, then there will be more of excess bicarbonate in your body. So that will cause alkalosis. And in gastric alkalosis, another mechanism is volume depletions as well as activations your renin-angiotensin system and the aldosterone systems, and that will cause hypokalemia and hypochloremia. So I will discuss in the later on that hypochloremia, hypokalemia, and activation of the aldosterone system is important factors for maintenance of the metabolic alkalosis. And this is the effect of the diuretics that cause metabolic alkalosis because of the volume loss, hypokalemia, hypochloremia, and the hyperaldosteronisms that we already know. Next slide, please. So hypochloremia, it causes the four effect. One, it reduces the bicarbonate secretions. If you have low chloride in the lumen, there will be less bicarbonate secretion through the pendant channel. I've already discussed previously. So there will be less bicarbonate absorptions. Another is low bicarbonate is sensed by the maculodenser cells, and there will be reduction of the GFR, so bicarbonate will get excreted less. And low chloride will stimulate the renin-angiotensin systems, and it will produce a state of hyperaldosteronism. Low chloride also inhibit the sodium-potassium chloride channel. Ultimately, there will be more solid load in the distal convoluted tubules, where there will be more sodium absorption at the expense of like potassium and the hydrogen ion. So there will be more hypokalemia. So hypochloremia ultimately causes hypokalemia as well. So hypokalemia, there will be alkalosis because of the increased ammoniogenesis, because of the activation of the sodium hydrogen exchanger, the proximal convoluted tubules, as well as the collecting duct. And in intercalated B cells, there will be down regulation of the pendrin, so less bicarbonate will get into the lumen, or there will be less bicarbonate loss. So ultimately, it will aggravate the hypokalemia. Renin-angiotensin systems, we have already discussed in the principal cells, it will cause hypokalemia and the alkalosis because of the more absorption of the sodium and loss of the potassium and the hydrogen ion. And intercalated A cells, there will be more secretion of the hydrogen ion and the will be absorption of the bicarbonate. And angiotensins 2 also increase the hydrogen ion secretions in the proximal convoluted tubules. So by these mechanisms, these systems actually causes alkalosis. So if you have a patient with alkalosis, you are supposed to take a complete history like if there is history of any loss from the GI tract or the through the kidney, diarrhea, vomiting, polyuria, any use of the blood product, like blood product have lots of citrate, and that actually converted into the liver and the bicarbonate, and that will cause metabolic alkalosis. And in PPN, we will use some gluconate, and that also get converted in your body the bicarbonate. So it will produce metabolic alkalosis. Hypertension, diuretic use. In examinations, you have to assess the volume status, whether the patient is a hypertension or the hypotension. This is very important information. And we have to do blood gas, electrolyte, urea creatinine, blood renin and electrolytes level, and urine potassium and the urine chloride. I must say that the volume status in the presence of severe alkalosis or where there is loss of bicarbonate to the kidney, the volume status cannot be properly assessed with your fractional excretion of the sodium. And in that situation, your urinary chloride is the better marker of your intravascular volume status rather than your sodium. That's why in evaluation of the metabolic alkalosis, we use urinary chloride rather than your FENA. Next slide, please. So in diagnostic evaluations, so if your urinary chloride is less than 20, that means your body is already lost chloride and kidney want to like absorb more chloride. So this can happen if there is loss through your GI tract or through the kidney, or if you have 65 and the loss is through the sweat, or you are using more of laxative. And if you have urinary chloride more than 20, then you are supposed to see whether the patient is hypertensive or the normotensive. If the patient is hypertensive, then you have to see the blood renin level. If it is high, then it is associated with the renal artery stenosis. Or if the blood renin and the electrolyte both are low, then it could be because of the Cushing syndrome, exogenous steroid, apparent mineralocorticoid excess syndrome, or could be because of the Liddle syndrome. Or if you have low plasma renin or high plasma electron level, that could be because of the primary hyperaldosteronism or tumor. If your blood pressure is low or the low normal level, then you have to see the urinary potassium level. If the urinary potassium is less, then it could be because of the laxative use, or it could be because of the hypokalemia per se. If your urinary potassium is more than 30, then it is because of the diuretic use or because of the tubular dysfunction, that is the Bartter syndrome. Next slide, please. Management of metabolic alkalosis, it is very simple, and most of the time it is conservative. So we have already discussed the role of your hypokalemia, hypochloremia, and the hypovolemia. That is the main factor for initiation as well as the propagation of the metabolic alkalosis. So we have to assess your volume status and optimize the volume status. We have to give the volume because of the sodium chloride. Ideally, we should not.
Okay, Ali, you have 2 more minutes.
Yes. And we have to treat the hypokalemia if that is there. We have to treat your hypomagnesemia. We have to treat the chloride loss with sodium chloride or the potassium chloride. And if it is the state of hyperaldosteronism, we can use spironolactone. And we have to treat the primary causes, and that is actually the GI tract or your kidney. And if we are using like diuretics in case of the congenital cardiac surgery patients, then we have to optimize the diuretics. Next slide, please. So if you have like severe metabolic alkalosis and you have to treat the pH like on urgent basis, then we can use some acids like hydrochloric acid, the ammonium chloride, arginine chloride, and they have some drawbacks as well. In most of the situations, what we have found, and I have found useful is acetylamides. If you use like low dose of acetylamides, most of the time it's cosmetically correct your pH as well as the bicarbonate. So to summarize, the metabolic alkalosis, the commonest blood gas abnormalities, respiratory compensations, the PCO2 is usually less than 60. GI and renal loss is the commonest cause of your metabolic alkalosis. We have to treat and find out your hypokalemia, hypochloremia, and the hypovolemia because these are the major factors. We have to primary treatments is basically volume replacement and electrolyte corrections, and acetylamides is sometimes used with a satisfactory response. Thank you all.
So thank you, Dr. Ali, for very nice discussion.
Rohit sir, questions we will take now or after the quiz?
Yeah, 1 or 2. I'll just settle. By the time I settle it out, you just take 1 or 2 questions.
Okay, sir. First question, Ali sir.
Sir.
How does hypokalemia cause metabolic alkalosis? First question.
So that I have shown in one slide. So one is when there is severe hypokalemia or it is a chronic hypokalemic state. So the hydrogen ion will get inside the cells. That is just because to maintain the electrical neutrality. Just in acidosis, the potassium will get out from the cells. So similarly, in alkalosis, your hydrogen ion will get, in hypokalemia, your hydrogen ion will get inside your cells. So there will be more hydrogen ion in the cells, in the proximal convoluted tubules, or in the cortical collected duct. So that hydrogen ion will get lost into the lumen at the exchange of your bicarbonate ion. So there will be more bicarbonate absorptions. Second, hypokalemia will increase your ammoniogenesis in your proximal convoluted tubules as well as the cortical collecting duct, and through that your hydrogen ion will get excreted, and at the same time you will have more bicarbonate ion in your body. Second, hypokalemia is also inhibit your sodium potassium chloride channel, so that ultimately leads to your more solute delivery to your distal convoluted tubules, where the sodium will get absorbed at the exchange of your potassium as well as your chloride. So you'll have more bicarbonate absorptions and alkalosis.
Okay, sir.
Thank you, Dr. Ali. So we'll move to the quiz session, our last session. So my screen is visible. So I'll quickly go through the Mentimeter app. So Dr. Niladri, please help me.
Screen is visible. Yeah. Screen is visible.
Yeah. So Mentimeter app. So all of you just click on the link and put your full name. I'm repeating, please put your full name for prize, because only we'll give prize whose full name is there, and we can't judge the rank without the full name. Number two is you will see the screen. You will go through the full name, then join will come. And once you join, it will show like this. So please don't click join another quiz at any time. Don't click join another quiz at any time. If at all you are lag in network, you can reload, but avoid all this. So don't press join another quiz. Then you will be out from the main quiz. So once I start, you will show like that. One question will come like that. Suppose which Indian song got Oscar award, like this, and you will get a time. You will see the time is gradually decreasing. So you have to answer it. Suppose the question is Eiffel Tower is situated in. So these 4 options, you have to immediately click on the correct answer. And if your answer is correct, your number can vary from this to this. Suppose the answer, you are getting correct answer 1000 marks, and immediately you are answering, you will get 1000. But if you are waiting your time going, by the time just before ending time you are clicking, you will get 500 points. So same correct answer, one person may get 1000 points, one person may get 500 points. So it is fastest finger first. You will see in between, you will see when the question is going, you may see you did not vote, wrong answer, loading results, like this. These options you will see. So according to your response. Then once your option is, you push the press button, you will see this either right answer or wrong answer. You will get your result immediately. So thank you, all the best. Any question is there? So again, you can be with Zoom, or you can leave the Zoom and only play with your smartphone.
Okay, Rohit, just one thing, they sometimes get confused regarding this. You have shown the do not press another quiz. So in that time, they have to wait for a few seconds. The next page will come automatically.
Yes.
Yeah, so that is important. So you may have to wait for a few seconds to next page to come. Otherwise, do not press anything. Okay.
Yeah. So you can be in the Zoom, or you can just leave the Zoom and join with your direct from your mobile phone. So any question came for this?
No question. I think they can join now.
Yeah, they can join, but quiz will start only if I start. Otherwise, before that, they can't vote.
Okay. I will tell them to join then. Okay.
In the WhatsApp group, you can write it down. Yeah. Screen sharing has stopped. So please join now. Also, you write it down that don't press anything else.
Okay.
So I have started. First question came. Only 25 people, 36 people.
Some code, somebody asking about code.
Yeah. Code is there, that same thing.
No question
Okay.
somebody asked. I think question
No,
will come only when you
Ques-
start, then only question will come. Yeah.
Yeah, question will come only start. So 42 players, 41 players. I'm waiting for many player to join.
Yeah.
So
They
me
can,
sir, it is visible na in Zoom
yeah,
also now.
they can see the screen now.
Yes, it's visible in Zoom.
So 40, I'm just waiting for the first question because as much as people can join, once join, then only I'll start. So 41 players, because once somebody misses, he will be back for a whole period. Yeah, 44 players.
Someone is still asking for code. Is there any code?
Code I already gave. Again, I'm sending. Just click, don't, no code is required because 44 players join means it is perfect only.
Yeah. Just click
Yeah.
click on the link. They can join, I think.
Just click on the link. So shall I start, sir?
44 people joined. 44 only.
Just wait for 2 more minutes, then it's the 45 has joined.
Yes, sir.
So shall I start, sir?
Yes, I think start now.
So
46.
first question. Yeah, 46. All the best. First question is coming. So your first question is coming on the screen. Which of the following causes predominantly hyperchloremic metabolic acidosis? Your time starts now, 15 seconds. So options are inborn errors of metabolism, hypoxemia, diarrhea, prolonged propofol infusion. So the correct answer is diarrhea. This is another name of normal anion gap acidosis is hyperchloremic metabolic acidosis. Question number 2. Yeah, already. Regarding anion gap, which of the following is false?
Rohit, sir. Hello. I think some network issues. Rohit, sir, I think there was some network issue.
Yeah. Sorry.
There was some network issue, I think. Can you share the screen again?
Yeah.
Yeah.
So third question. No matter the etiology, acidemia affects the cardiovascular system. Which of the following is false? So other options are correct. Acidemia decreases cardiac contractility. Question number 4. Question number 5. All of the following are true about metabolic alkalosis except associated with decreased ionized calcium, associated with hyperkalemia, arrhythmias are a potential complications. Chloride responsive metabolic alkalosis have symptoms of volume loss. So associated with hypokalemia. Very good. Many people answer correctly. Regarding compensation, which of the following is true? So majority corrected. Lactic acidosis is caused by all of the following except excellent. Prolonged use of diuretics infusion may lead to metabolic acidosis, decreased acid secretion, contraction alkalosis, chloride resistant metabolic alkalosis. So it is contraction alkalosis. It is chloride responsive metabolic alkalosis because volume can help it. Which of the following conditions will not cause respiratory alkalosis? Fever, tachypnea, anxiety, hyperventilation, encephalitis with neurogenic hyperventilation, obstructive sleep apnea. Excellent. Regarding physiology, which of the following is false? Anderson-Hasselbalch equation. Then we have H plus. Then we have Stewart approach needs strong anion gap. Davenport nomogram is only useful in ventilated child. 4 options are there. So Davenport nomogram can be used for others also. Injection sodium bicarbonate may lead to worsening of hyperkalemia, lowering of intracellular pH, decreased generation of CO2, may lead to volume depletion with hypernatremia. So may lead to volume depletion. No, it won't lead to volume depletion. So it lowers the intracellular pH. Air bubble in the ABG syringe may lead to all of the following error in blood gas value except may spuriously increase PO2, may spuriously decrease PSO2 in ventilated child, may spuriously decrease PSO2 may spuriously decrease pH. It's nothing to do with pH. Ventilated child may get very high partial pressure of oxygen, so it can falsely lower PO2 also. Niladri taught. Most effective buffer system. Bicarbonate buffer. Excellent. Respiratory acidosis, which of the following is false? Good. Excess heparin may lead to all of the following. Which of the following ABG error? Good. This is important for internal consistency. Which all of the following drugs can cause acidosis except? Perfect. Chloride resistant metabolic alkalosis with hypertension. Perfect. All are true for renal handling of acids in metabolic acidosis. Excellent. Avoid excessive shaking of ABG syringe as it may cause hemolysis. Excellent. Ketoacidosis is caused by which of the following except? Great. Some IVM can cause ketosis. So the first lecture as well as the Dr. Subhadeep's lecture. Excellent. Perfect. Last question. High anion gap metabolic acidosis is caused by all except. So it's over. So now the time for result.
So I think 48 have participated. Huh?
Oh, sir, great, sir. So results
Great.
are coming now.
Okay.
So the first three, sir, Dr. Kanuri, Vargavaram, then Orko and Dr. Narayan Santuka.
Okay, so first is prize to Dr. Kanuri, second is Dr. Orko Prabhu, and third is Dr. Narayana.
Yes, sir. So unmute. Can you unmute them, sir? All of
Thank
them
you.
registered and none of them are faculty in the, sir. Like,
No, none of them are faculty. Somnatha, can you please unmute or give them in the panel? Hello?
হ্যাঁ বলুন
হ্যাঁ এই Kanuri, Dr. Orko Prabhu and Dr. Narayana.
ওকে প্যানেলে নেব কানোরি
Well, sir, you can stop screen sharing.
huh.
So congratulations to the winners, Dr. Kanuri, Dr. and Dr. Narayana. Thank you again. Yes, Dr. Kanuri has joined. Can you introduce yourself?
Good evening, sir. I am Dr. Bahadur Ram, sir. I am working as emergency medicine senior resident at AIMS Rishikesh, sir.
Okay, great.
Third one, Orko Prabhu, Kanori, and third one.
Dr. Narayanan.
Narayan Santuka.
Narayana, I think he was also consistently last season. Also, he was one of the winners, no? In fluid electrolyte.
So Dr. Orko Prabhupal, MD Pediatrics, PGT at BC Rai Hospital, sir.
Okay.
Hello.
Yeah.
Okay, so I will request Dr. Kanuri, Dr. Orko Prabhu, and Dr. Narayana to send your full name, contact number, address, and your details, bank details to one of us, either to WBAP email and or directly to Somnatha. Somnatha, you can write your phone number in the chat box. Yes, Orko Prabhu, can you just unmute yourself and introduce?
Myself, Dr. Orko Prabhu Pal. I am third year MD PGT from Dr. BC Roy PGIPS.
Congratulations. Congratulations.
Thank you, sir.
And Dr. Narayan?
Hello.
Yes.
Good evening, everybody, sir. This is Dr. Narayan. I'm currently working as senior resident at Bhimabhoi Medical College, Balangir, Odisha. Thank you very much again for this event. Thank you so much.
Thank you, and congratulations to all the winners. If you have a direct feedback, we can give it quickly, 1 or 2 feedback. For the we are planning to go on this type of symposium again at least 5 to 6 this year. So if you find it some topics are very useful for the next session, then you can just give us your opinion. We can think of it.
Dr. Kanuri or anyone, any feedback? Dr. Narayan, Dr. Arkaprabhu.
Very interactive session, sir, but unfortunately I missed the first part of this session. When will the video will be uploaded, then I can see it later. Due to my
Are you
duties, I
in the
missed.
WhatsApp group?
Yes, sir.
Yes, so first day YouTube link already I think shared in the group. Today's link will be shared soon after within a few minutes, okay?
Okay. Thank you, sir.
Hello.
Yes.
Yes, Dr. Narayan.
Yes, sir. Sir, just one thing that I have been participating and I've been sharing the flyers like in all my groups. But if officially, you can like ask other people like from Odisha, I would love to see like the postgraduates, even a lot of DCH students are there who can come and actually get benefited. So that would be a nice thing because this kind of events from West Bengal IIP has been consistent over the last 1-2 years that I have seen, and even the conferences I have attended, quite a few I've gone to Kolkata and attended, and all of them have been quite, very much affordable for all of us and very much accessible for people from Odisha to go and attend in Kolkata. So I think we can do that, sir, if possible, and nothing is like it is very much feasible if you think about it.
Sure. Thank you. And one suggestion is that on POCUS, yes, POCUS will be very good suggestion, but it's bit difficult to do on online because you will not get the feel of hands-on. But still, if you have a video, you can practice on your patient. If you get the videos, then that may be helpful. So basic knowledge, and we'll try as much as video we can upload in the POCUS and in a practical way, recording in a good way, then we can do it. But that will be a bit costly, so we may need to hike the registration fees a bit, because video recording needs a good video recording to focus for online. Otherwise, it will be not understand.
Sir, last year we had an ECG and X-ray combined, right? So we can have an X-ray separate because very less time was given for X-ray, and that is also feasible. And over 2 days, it would be very exhaustive.
Okay, so X-ray, separate X-ray, all type of X-ray, you can cardiac, respiratory, bone X-ray. Okay, we can do that. Separate X-ray, and one focus is another suggestion. Okay, good. Ventilation. One is ventilation. Yes, same thing. Ventilation doing in the online bit difficult. We are having our East Zone Critical Care Conference here at Calcutta on 13th and 14th of July. So 13th July is the workshop, and there will be mechanical ventilation workshop focus as well. So you'll share the flyer and the registration link in the WhatsApp group. You can think. Otherwise, after that, after X-ray and focus, we can think about the mechanical ventilation. But again, these are the workshop which needs very hands-on, and presence will be much better than online. Still, if you have a demand on that, then we can do it. Okay. Okay, I think Somnath, you can write the WBAP email in the chat box, so they will send their details of the bank details and phone number and full name and address in the email and WhatsApp. Okay, so we'll send the prize money to them. Okay.
Okay.
So how much is the prize money, sir?
So last year, so 4,000 for winners, 3,000 for the first runner-up, and 2,000 for the second runner-up.
17 lakh. That's nice.
Okay, and I will request now Rohit and Niladri, because you have done excellent job, and all the hard work being done by you, and the whole controlling these 2 days and organizing, especially the quiz one, is just matchless and awesome. And I want to hear from both of you, and we can also like if we do the intensive care related symposium, so you both can be again the convener.
So Niladri, any comments?
Thank you, sir, for the opportunity. It was quite nice, sir. We tried to adjust the time, but maybe second day there was a little bit of overshooting. Yesterday it was quite accurate. We finished just on time, 8:30. And participation was also very nice. More than 150 registration was there, and many of them, I think they have learned something new from this workshop, especially the Stuart approach, which I think always is difficult. Even if you read it from the book and all, that is a new thing I think they have understood now. And a few of the concepts like Ogni sir's lecture yesterday and today, Dr. Shubhadeep and Dr. Ali, that will help them in their day-to-day life. Thank you, sir.
So anyway, it is,
Rohit.
sir, I was there for the last year also, and this year participation is very good, and their questions were very interesting, and they were interactive throughout the session. So thank you, sir, and thank you, WAP, for giving me and giving Niladri the opportunity for doing this wonderful academic fest. So that's all from my side.
Okay. So we can end, and thank you, Somnath, for your 2 days whole support and the link, making the group, the managing the registration, making the WhatsApp group and panelist link, and managing the also the participant WhatsApp group. This is a huge task, and thank you from West Bengal IAP for your work and your support. So we can end here.